So I'll move on and just talk a little bit, as Donna said, about the delivery programme that's been commissioned by the NHSE Genomics unit. So this is a 2-year programme of activity with the hope that this then becomes embedded in clinical practice where appropriate in our pathways of clinical care. And that's why it's so great when I look through the attendance list today to see such a broad range of nurses, midwives, clinicians, people working within health in the room today, because actually I can see a broad range of geography, of different types of organisations and types of roles that you're all in, which is fantastic because that's exactly the sorts of audience we need to be able to spread the word and for you to be able to go back to your practice and think, where can genomics fit in what I do? And actually as a nurse, midwife, healthcare professional, part of an MDT, how can we introduce the conversation to then lead on to conversations about what processes and support infrastructure I need in my clinical area to be able to bring this to the patients that we see. So it's great to see such a broad range of people in the audience. So the programme has been commissioned. It started in essence at the end of last year, beginning of this year, and I'm really pleased that my colleague in arms, Emma Tonkin, is also here today. So Emma is the academic lead for the programme and I'm the nurse lead for the programme. And we have 2 main commissioned outcomes. One is very defined, one is less defined yet absolutely essential. So the first one is to explore the nursing pathway across 7 selected pathways of care, and they were selected for their genomic, for the ability to influence through genomics. So 4 of those are cancer pathways and 3 of them are rare diseases. And one of the things that became very obvious to us quite early on was that our title was Nursing and Midwifery, but our focus had become more nursing, and we really wanted to make sure that we recognising all the fantastic work that's been happening in midwifery for many, many years, probably before nursing actually, in genomics area, that we were really bringing that voice to the fore. And we've been very fortunate that we also have a group of midwives nationally who've been working on a bid, a midwife-led bid about where we need to focus our efforts in understanding the opportunities more for midwifery, and you'll be hearing more about that during the day and this afternoon from Donna and Denise, who are in the room with us today. And the second ambition is to broaden the knowledge and impact of genomics across nursing midwifery family, which is everybody. So I'm a nurse of different sorts, general, children's, community. You know, most of our interactions actually happen in primary care. And really, as an individual, as a patient, as a family member, when we're ready to ask the question, we may not be in the outpatient appointment, we may be anywhere. And actually, it's really important that when we are ready for the conversation and we want to ask a question, that whoever we ask is able to give us either the appropriate answer or signpost us and really just pick up the question that we're asking, because we sometimes don't ask it in a very clear way. Sometimes it's just more of a general conversation, but it's our skill as clinicians to be able to pick that up and signpost on it. So that's where you'll see a much broader educational informatics comms programme around raising awareness of genomics and building on the great work, as Janice indicated, from HEE around education at all different levels, from 10-minute online bite-sized to master's degrees in genomics for healthcare professions. And again, although our focus is nursing midwifery, we would be really naive to not appreciate that all of our pathways are multidisciplinary. And we'd be nowhere without our diagnostic radiography, our pathology, our all of those colleagues that make our pathways work alongside us. So although the title's nursing midwifery, when we've looked at these pathways, we've invited those people from whatever professional group, or whether it may be social care, or wherever, who are involved in that patient journey. I'm clicking, but with no... Oh, there we go. So it was really helpful, I think, particularly for Emma and myself, to be able to demonstrate just the breadth and reach of this programme of activity. So this is our first data collection of the reach of how many people, you know, because that this programme has touched, as far as we know, in obvious terms, like that's you being in the room today, you joining a webinar. So this represents, of the 7 GMSAs, this just represents the figures from 3 of them over the last few months. And you can see that already we're reaching people in the thousands rather than the tens or the hundreds. And that will be a drip, that will be a snowball effect. So every time somebody says to you, where did you go today, what was it like? All of a sudden you're having a conversation that mentions genomics. And the more that that conversation perpetuates, the more that awareness raises. So you can see that those are the touch points of people in the room or people on the webinar, but obviously we anticipate that for every one of those individuals, there might be 1, 2, 3, 4 people that they talk about what they've shared and what they've learnt in that connection. So really starting that engagement piece, and that's been really led by the GMSAs, and it's great, and I think we need to really congratulate Annette and Vicky for their work today and their team in the east of England, the whole GMSA team who brought events like this together and who build the webinars and a lot of the activity that people access all the time. So a big thanks to the work that's going on across all the GMSAs to deliver these opportunities for us all to dip in. One of the other things that we talk about here is networking. I know you've got on your programme to network at lunchtime, etc. I used to work with a lovely lady who used to say, you never know who you're sitting next to, and the person you're sitting next to today could change your life or your career. So always take time to say hello to the person you sat next to, get to know them, ask them a few curious questions, because you will find connections and you'll meet fantastic people, almost by definition, because you're all here showing the curious mind and the interest to want to know more. So don't miss this fantastic opportunity to network and connect across organisations, across regions, but across professions. And in some ways, that's what our pathway projects also enable us to do. So we've got a 2-year programme of activity. You can see the programmes that we're working on. You can see that we've started lung cancer, which is just coming to its conclusion, hereditary epilepsy, the midwifery scoping, feto-maternal work, breast cancer programmes just started, and we're just starting ovarian. So we're well on our way through our programme of activity. And each one of those takes several months to complete, and I'll explain why. Each of the GMSAs leads on one of them, but the anticipation is that then our findings are disseminated across all of the regions so that is an England-wide coverage for each of these activities. And what does a pathway project mean? Well, I don't know if any of you have been involved in agile working, something called sprint working, but it basically means a very focused, planned period of activity. And that's where we have national workshops. So from each of the GMSAs, we do a scope, they do a scoping about what the project is, which part of the pathway we're looking at, who are the stakeholders then involved in that part of the pathway. And then we ask our regional colleagues to come together and nominate potential people who'd be interested from their region to be part of a set of national workshops, which are run by the region together with Emma and our colleague Mark. They're online, and they're based on several questions which relate to the outputs we're there to produce, which are, what's the genomic pathway? How does that fit onto a clinical pathway structure that is produced by HE, which is all about the educational requirements you need at certain points in that pathway of care. Things like looking at equity of access, because we know access to services is a real thing that needs to be looked at across the country. Some of these services evolved, and they need to now be planned to make sure we have equity of access through geography, socio-economic, various areas of those challenges. And also to look at the patient story and patient experience. So those workshops are people from all over the country. And I would say we term them a national reference group, because actually those are people who are experts in their field, and they're also people who might never normally have the opportunity to meet each other. So some of the cross-learning between each other in the conversations has been really beneficial, and some of the interesting varieties in experience and service is also very clear. So we run 5 of those workshops to produce our outputs, and then hopefully continue to engage with that national reference group to make sure that we're on the right tracks, and also to support them with service changes that become quite clear as to where those need to be through the workshop activity. What do we produce? Well, I talked about the Clinical Pathway Initiative, which is a document, and I'll show you a bit of a snapshot of one. Patient story, and that can be a variety of patient stories. Obviously no 2 people are the same. We can be the same age group, the same demographic, the same ethnicity, but we're all different people. For every 10 people, there are 10 experiences. So It's really important that our patient stories aren't just generic, but we try and represent some range that people can identify with if they're about to work through their journey. We also use information to inform an online resource called Genotes, which again is an HE program of activity which is there for clinicians, very focused in some areas for the highly specialised clinician. And what we're adding to that is a viewpoint from the people in the workshop about the things that they found useful or the things they would like to contribute. Again, talking about opportunities for developing genomics in care. So we know the National Test Directory exists. We know that there's a list therefore of what can be ordered, but it also says who can order it. We also know there's regional genomic labs. Some do lots of tests, some do very specialist tests. And it's really understanding in your area, what's your process to understand the genomic opportunities? Where does that conversation happen in your pathway? Does it normally come from you as the nurse or another member of the MDT team, or is it the medic, or is it a clinical geneticist? Who is that? Who could it be, and who should it be? Because actually, if somebody in that pathway sees the patient for 80% of the time and they have a really good therapeutic relationship, could it be them? Do we need another loop in the chain that's a referral and a waiting time for a conversation? So it's really encouraging that thinking about this is what we have now, but actually what's the best thing from a patient perspective, and what services do we need to develop or processes do we need to change around that? And that's very much stimulating that thinking in the members of the reference group. That's why the national coverage is really helpful. And that national group of clinicians, we had a conversation with Healthwatch quite recently, which was really helpful to us about our patient involvement, patient public voice. We do involve patient and the public when we're mapping the pathways and the scoping and thinking about who needs to be involved. But actually we were thinking about, is there a value here of having a separate group that's actually for the patient public representatives, for them to generate their own outputs that would be helpful for people going through this programme. So very much an iterative development process that we're learning as we go through, but really trying to make it as useful and as helpful for those people in any healthcare setting, for the patient, their family, and for the person who's delivering the care. So those are our outputs. Those will be fairly standard across most of those pathways, with a couple of exceptions. What does it look like? Well, some examples here. So the one on the left is the lung cancer pathway output around an infographic for you to use that can be used as a poster in clinic. Again, guided by the reference group about how they want that to look. QR codes, it will take you through the 4 levels of where you've self-identified yourself in your training. We've changed the graphic slightly up there, but it is novice, competent, proficient, expert, which people of my era will probably recognise as BENA. But very much identifying where you sit on the pathway, what the skills you need in your role, so you can go straight to where you can find the resources to help you with that knowledge base. What you can see at the top with the graphics of the tree and the tables underneath, you can't really read, but they again are that working with the HE Clinical Pathway Initiative together with the table underneath to create the image of what the pathway is, and underneath the skills that are required and where you can find them. So very much a pragmatic, useful resource for you to be able to upskill without needing to spend a lot of time trying to find where the appropriate information is. We also found some really useful things from a practical viewpoint about what terminology people use. So we term it genomics. In the lung cancer pathways, it was described as molecular testing. So again, just making sure that we're checking with ourselves that we're all mean the same thing, and there's no question that's ever too basic, and we should always check with each other to make sure we're not assuming things of the conversation. So I think those are all really helpful to know as well, and that's what you get when you bring a group of people together. So I'm conscious of our time, so I'm just going to draw to a close, but I think it's really important that, so regionally, Vicky Carr, Vicky, if you give us a little wave, is your lead nurse for East of England, and obviously Annette is Vicky's colleague and working in East of England as well, so you have a touch point and someone you can meet while you're here. There's myself and there's Emma, if you want to email us about any questions or queries, but we are here, we're here all day, as they say, so please feel free just to come along, say hello, and if there's anything you want to talk through, please do. Thank you.
Oh, hello, me again. So just for those of you who missed me at the beginning, I'm Annette Breen. I'm one of the lead nurses for the East GMSA, along with my colleague Vicky Carr at the back. And I'm going to present on what is the East GMSA and what is it doing. So I think you saw the maps from Janice and probably Naomi about how the GMSAs are structured. As you can see, there are 7 across the country, and they don't quite map to an NHS England or other geography, but they are centred around a genomics laboratory hub. So our region, the East, centred around Cambridge. And why are they here? And I think the main reason is to drive equality, equity of access for patients to genomic technologies to inform their treatment and diagnosis. Because as we know, for patients who are attending large tertiary university hospitals, they have access to different technologies to perhaps patients who are attending smaller hospitals in rural areas. And we want to sort of ensure that patients have equitable access to research trials as well, because that can improve patients' care. And if we just look a little bit more closely with the East GMSA, you can see it extends from Derby Hospital, Derby and Burton Hospitals, over to Essex Partnership, Lincolnshire Hospitals, down to East and North Herts. So we've got 29 trusts, and there are 4 principal partnership trusts, which are Nottingham University Hospitals, Cambridge University Hospitals, the University Hospitals of Leicester, and Norfolk and Norwich Hospitals. And those 4 organisations, if you like, host the resource and the staff for the GMSA, because I suppose the GMSA is a kind of virtual organisation. And so you can see we've got acute trusts. I think there's 16 acute trusts, and then we've got 29 trusts in total. And as I said, the Genomics Laboratory Hub is at Cambridge, and we've also got laboratories at Leicester and Nottingham University Hospitals. So as I said, our key aim is to ensure equitable access and standardised end-to-end care pathways, access to treatments and medicine optimisation for genomics. So some of you might be familiar with genomics for testing, for diagnostic reasons, but there's also quite a lot of developments that have occurred, which means that patients can have medicines that are tailored specifically there for their condition. I think one example is the DYPD gene for chemotherapy 5FU, which is commonly used in breast and lung cancer. Some patients have a variation in that gene, which means they're at greater risk of toxic side effects, so can end up with intensive care and really, really poorly. So all patients should be tested to find out if they have this variation. And then if they have, they can be offered a different chemotherapy agent, which is good news all around because it reduces the nasty side effects for the patient, better outcomes, and good news for the NHS because it reduces length of stay, reduces costs with better outcomes. So when we sort of think, well, what have we been doing in the East GMSA? So Naomi talked about the National Transformation Project. So last year in 2021-2022, when we just got going, we started off with a baseline assessment. And this was to sort of look at where is genomics in nursing and midwifery across the region at the moment. So looked at things like education and workforce, clinical practice, infrastructure, collaboration, patient and public involvement, and leadership and strategy. And it was just a sort of toe in the water to find out how genomics is actually on the ground. it's not a sort of randomised control trial or anything. So it was a survey, and we talked to chief nurses, clinical nurse specialists, midwifery specialists, colleagues in higher education institutions to give a picture. And as we'd expect, it's because we're at the very beginning of this journey of embedding genomics into the NHS more widely. As we'd expect, it was very variable. There are some areas, beacons of good practice, but on the whole, it was at quite a low level. So we've also done some work on Lynch syndrome, which I'll come to speak about in a moment, and monogenic diabetes, which I'll come to speak about at the moment. And then the National Transformation Programme's projects for 2022-24, which Naomi's outlined. We've got 4 cancers, 2 rare diseases, polycystic kidney disease, familial epilepsy, and then also the feto-maternal pathways. And I suppose one of the questions is, why those? So they've been picked, as Naomi said, for certain reasons because they have got genomics included in them. And also, we've got to start somewhere because there's thousands of patient care pathways across the NHS which involve genomics. So we need to start somewhere and use these as a proof of concept, I guess. And we're looking at delivery of change at key points in the patient pathway so we can facilitate access to genomic testing where it's advantageous, inform best practice guidance for pathways, and then identify learning and development opportunities. So the East GMSA will be leading on autosomal dominant polycystic kidney disease. And this causes cysts in the kidneys, but also the liver and pancreas, sometimes the pancreas. It's typically diagnosed in the sort of, I think it's the 40s onwards, and causes renal pain, reduced renal function, high blood pressure, renal stones, and about half of people with this will get renal failure by the time they're 60 years old. Then the numbers affected, because it's quite underdiagnosed, they're reported very variably. So the PKD, Polycystic Kidney Disease Charity, reports 1 in 1,000 to 1 in 2,000. And genomic testing can be used to help plan patients' care pathways, their frequency of follow-up, also important for live donors, and also to help inform reproductive choices. And treatments that can reduce patient symptoms and risk of complications, so it's better outcomes. So across the bottom, you can see that polycystic kidney disease spans the whole lifespan from preconception, pregnancy, neonates, pediatrics, right through to adults. So our project, we're sort of, part of the work is to identify the optimal part of the lifespan of disease to focus on. So we're working with key stakeholders, so that's renal services across the region, charities, and patients and their families, reviewing current pathways and guidance, defining the scope of the project, so which part of the lifespan we'll focus on. And then in February next year, we're going to start a series of workshops, and they'll focus on clinical pathways, clinical competencies, the context, the geography in which the service is delivered, and equity of access. Also looking at feto-maternal pathways. So Naomi mentioned the Genomic Test Directory, which is available online, which NHS England publish, and it details all the genomic tests which the NHS is currently funding. So it's subject to revision quite frequently. So there's a series of tests, so fetal anomalies with a likely genetic cause. So that could be an aneuploidy, where there's a difference in the number of chromosomes, whole exome, where the whole strand of DNA is looked at. So we break the DNA down into the genes, and which is about 2% of the DNA. And then also there's the non-coding DNA. And we're looking at large panels, microarrays, and copy number variations. So in the east of England, we're planning an audit to look at referral reasons, rates, test accuracy, outcomes, turnaround times, and failed or inconclusive tests, and equity of access. Then also nationally, there's a 12-month project to understand how the test, if offered, the scope, gaps and challenges. And Denise Barnes is going to present on that this afternoon in our midwifery parallel session. We've also got a NICU PICU project. So about 15% of newborns are admitted to NICU. And quite a number of these babies are really poorly. The initial clinical presentation doesn't always predict the outcomes. The babies have been subject to many invasive investigations, which might be sequential, that the results of one test has to be waited for before another is being done. So whole exome, so looking at the bit where the genes are, and whole genome, so looking at the bits of the DNA where the genes are and also the non-coding DNA is available for very ill children with a likely monogenic disorder. And that's fantastic because it means that these children and their families, the children can avoid a lot of invasive, nasty procedures. They can get a more timely diagnosis to inform their care and treatment pathways more accurately. So where does nursing and midwifery fit into this? So the consent process for genomic testing is quite complex, and it should include that the results might inform future health conditions as well as diagnosis. The scope and limitations of the test needs to be explained, and then the possibility of additional unexpected or incidental findings. And I think perhaps a common one that might come up might be non-paternity. And then outcomes can be uncertain or unclear. So the projects we've got going, so we've got a transformation pilot study across 3 of our trusts. So Nottingham University hospitals, there's some genetic counsellors undertaking this role to consent parents and families. Cambridge University hospitals, registered nurses. And then at UHL, they're going to recruit a genomics practitioner. So that's a real development for that, and we will report back on this, hopefully at a future conference. One of the other work streams I mentioned is Lynch syndrome. This is an inherited cancer predisposition syndrome that increases an individual's risk of developing quite a few nasty cancers, bowel, endometrial in particular, ovarian, gastric, pancreatic, small bowel, and renal as well. And it's really key. So at the moment, there's quite a lot of work on bowel and endometrial because they're more common. So I think it's about up to 5% of bowel cancers, a patient will be affected by Lynch, and about 3% of endometrial cancers. And it's really important to find out if somebody with those cancers has got Lynch syndrome, because that will determine their longer-term follow-up. And the way that this happens is when the tumour is excised and sent to the laboratory, it should have some initial testing to find out if particular proteins are present or absent in the tumour. If these proteins are absent, it means that the person is at risk of Lynch syndrome, and then they can be offered genetic testing. So at the moment, it's quite a long, drawn-out pathway for the patient, And there's work in progress to improve pathways for patients diagnosed with these cancers to identify those at higher risk. And then identifying them at higher risk, it means just because they've had bowel cancer once, they're still at risk of bowel cancer, so it might inform the type of surgery they have. And also, genetic testing could be offered to their first-degree relatives if they're found to be affected, so that they could be offered screening, which would mean, good news again, earlier diagnoses of bowel cancers and potentially risk-reducing measures. So Vicky Keisel, who's a genetic counsellor at UHL, and Leanne Barrett, who's a patient representative, who's affected with Lynch, will present on that this afternoon, so I won't say too much more about that. And one of our other work streams is prostate cancer. So just about 12% of men will get prostate cancer. So some men are at higher risk, those who are over 50, black men, first-degree relative affected. So NHS England have funded a project, United Against Prostate Cancer Action, which involves genomic testing on the tumour to inform the most appropriate treatments for men and whether the man has an increased risk of an inherited predisposition. And Gemma Gunn's going to present on that this afternoon, doing a what's coming next, aren't I? So. And also one of our work streams is monogenic diabetes. Diabetes, my experience in nursing, hugely complicated. So monogenic diabetes, rare type of diabetes, accounts for about 2% of diabetes cases. And typically it would be people who are diagnosed as babies, there's family history of mature onset diabetes of the young, or any type of diabetes diagnosed at a young age. And then there's diabetes, it doesn't quite fit type 1, it doesn't quite fit type 2, somewhere in the middle. So genomic testing is needed to identify the most appropriate treatment for people with monogenic diabetes, because sometimes people have been put on insulin inappropriately and their diabetes isn't managed. And for some people, it means that their treatment can be sort of more diet controlled and things like that. So it's really life-changing for a lot of people. So Health Education England funded a national project to support genetic diabetic nurses. The GMSA supported the project through clinical leadership and engagement with senior medical and nursing colleagues across the region. So in the relevant trusts, because it's not relevant to all trusts, trained at least one adult, paediatric nurse and doctor. And this has increased referral rates and diagnosis, reduced variation across the NH trusts, and also our GMSA, we have a regional monogenic diabetes network every couple of months. So here's our referral. So you can see, So this is our referrals. As you see, they're nicely increasing steadily over this year. And the pickup rate as well is picking up as well. So that's really good news. So all these people will be getting more effective, appropriate treatment for their condition. We've got familial hypercholesterolemia, which is an inherited condition that can cause very high cholesterol levels. Affects about 1 in 250 people. And if it's untreated and undetected, can cause serious heart disease at a very young age. And so in the Norwich area, we've got a pilot project just starting off with a clinical nurse specialist developing a hub and spoke model to coordinate the service rather than it being at an individual GP practice-based level as it is at the moment. And then just to plug, if anybody would like to join our Nursing and Midwifery Genomics Links Forum, we meet every 2 months for an hour over Teams to share information and updates. Quite a few of the trusts have already got a Genomics link, but that doesn't exclude you from joining. And it's to cascade in, so the purpose is mainly for us to share information with you, to cascade across your trust. To the and then one of the things that the Links Forum helps us with. So I mentioned the 7 work streams. So our genomics links are key to helping us identify relevant clinical nurse and midwifery specialists in their trusts to work with us to improve the pathways. And that's our team. So Melissa, one as associate nurse based at Norfolk and Norwich, myself, Vicky, and Katie, our project manager. And I was very bad with the housekeeping because I forgot to say we've got a question and answer session at the end of this morning with speakers from this morning. So if you've got any questions, please write them down and ask them. We've got tea and coffee now in the room just there. And I also forgot to tell you where the toilets are. Oh, no, just downstairs on the ground floor. So thank you so much for listening, and have a cup of tea and refresh and chat amongst each other. Thank you. And our first speaker is Professor Alison Pilnick, who is a Professor of Language, Medicine and Society at University of Nottingham. And her special area of interest is sociology of health and illness, and especially the interactions between health and social care professionals and their patients and clients. So much so, she's been researching it for 25 years, which is fantastic because in 2015, Alison became a Fellow of the Academy of Social Sciences in recognition of her work. And she's got a special interest in how patients, clients make their decisions about screening and testing based on their interactions with healthcare professionals. And she's going to speak to us about this today with a special focus on where English is a first language, not a first language, and other languages are first language, not a first language. Thank you. I'll hand you over to Alison.
Thank you, Annette. And thank you especially for telling everybody how old I am. So it's really nice to be here today. And when Annette first asked me to speak, I said, I could speak about the comparative project that I've been working on that looks at antenatal screening in the UK and Hong Kong. And then I was thinking that I know that all of you in the room, or many of you in the room, work in very different clinical areas, and you may not work particularly in the field of antenatal screening. And so I was trying to think, what can I pull out from that work that might be relevant to everybody, whatever service they work in. And so I decided that what I would do was to talk about those projects, but to talk particularly about the work we did looking at consultations where there was shared first language and where there wasn't, to see what impact that had on how things panned out. So that's what I'll talk about specifically. But if anybody at any point later in the day wants to ask me more about the rest of the projects, I'm really happy to talk about that. So just to give you a bit of background, I've been working with colleagues at the University of Hong Kong, and particularly Professor Olga Zeitz, who's based there, since 2009. We've had several grants, some funded by UK funding bodies, some funded by Hong Kong funded bodies, to look at different aspects of antenatal screening there. And our starting point back in 2009 was that there was an existing body of sociological work that showed how professional-client interaction and how what happened in that interaction was so important in terms of the decisions that people ultimately made. And obviously the references that are on that slide now are old references. There's now much more work than that. But what we were interested in when we first started doing this work was that much of the work at that point was interview-based. So there was lots of work asking women, asking midwives about their experiences of receiving or delivering screening. But there wasn't that much work that actually captured the detail of those interactions. And the other thing that we were interested in was that lots of the work that was out there was in largely monolingual settings, or at least, even if it wasn't in largely monolingual settings, it tended to look at consultations that were conducted only in shared languages. So we decided that we would use, by preference and mostly video recordings, occasionally audio recordings, and we used a conversation analytic approach, and I'll talk a little bit more about that in a minute. So, I mean, this won't be news to any of you in the room if you're engaged in practice, but obviously healthcare encounters that involve participants who are from diverse backgrounds, who don't necessarily share first language, are becoming much more common across health services generally. But there isn't a whole lot of empirical data on how those consultations play out in practice. And that makes it difficult to document the extent of the challenges and to see where challenges are shared across services and to think about what might be done to address those challenges. And I say there isn't much work. There's the kind of notable exception of Celia Roberts' work, and Celia is based down at King's. And she's done some work on language use and understanding in these kinds of intercultural contexts. And what she's always very keen to stress, and what I think is really important, is that there's no obvious marker that denotes a language barrier with patient A but not with patient B. You know, it's not necessarily something you can get from looking at records. It's something that unfolds through a consultation. So you're working on your feet and thinking on your feet, trying to work it out. So I said that we used a conversation analytic approach. So conversation analysis is a sociological method, but it draws on insights from psychology and from linguistics. It involves audio or preferably video recorded consultations, and it involves the very detailed transcription and analysis of those to look at how interaction unfolds in the moment, to look at how different ways of presenting decisions are responded to look at how and where effective practice is established, to look at how and where difficulties arise. So I won't say any more about that now, but again, it's something I can talk about for a really long time if people are interested to follow that up later on. But what I will say is that there is now quite a significant body of conversation analytic work in all areas of healthcare. And what that points to is really how pivotal the way in which professionals frame choice is for the decisions that people actually go on to make. And sitting alongside that, and relatedly, there's also a smaller but growing discourse analytic literature that looks specifically at intercultural communication. And I guess that's a broader field because culture is denoted by very many things, and language use and what language somebody might use is only one of those things. And so it's interesting to see, I think, that those intercultural studies don't assume that language is necessarily a significant variable a priori. What they do instead is look at how that pans out. And I think because they approach things in that way, they don't start from the idea that there is inevitably a barrier. They challenge some of the received wisdom about good communication. So what Robert's work does, for example, is shows that actually extended explanations can, rather than being the way to resolve understanding difficulties, actually create more confusion, because you end up in a cycle whereby you're trying to pass on information that isn't understood, and it's difficult then to get out of that cycle. Oh. There we go. So in terms of the data that we had, or the data that I'm going to present from today, we recorded 120 consultations, and today I'm going to talk just about the consultations recorded in Hong Kong. And I'm going to do that because the nature of the population in Hong Kong meant that without setting out to do that, we recorded an incredibly diverse range of consultations between an incredibly diverse range of speakers. So all of the consultations in the clinics that we recorded from were conducted either in English or in Cantonese. But that sample included people who were speaking Cantonese as a first language, people who were speaking it as a second or subsequent, and the same for English. And they originated from places all over the globe. So from parts of Asia, from North and South America, from Europe, from Australasia. As I've said, the consultations were either conducted, or we categorised the consultations into three groups. So we looked at those that were conducted between two first language speakers, be that of English or be it of Cantonese. We looked at those that were between two second language speakers, and we looked at consultations where one person was speaking a first language and another person was speaking a second or subsequent language. I should say that I don't speak Cantonese, and that the translation of the Cantonese extracts and the primary analysis of those was initially done by my colleague Olga Zeitz in Hong Kong. We used conversational analysis as our primary method, and really what was driving this part of the study was this key question that's on the slide just there. So how does the presence or absence of a shared first language, how does it impact on these consultations? What effect does it have? And we were particularly interested in what effect it might have in terms of the delivery of screening test results, and then on the subsequent decisions that were made as a result. So before I talk to you about some of the results, and I'll show you some of the data, some of the extracts from the consultations, I just want to say something really quickly about this L1, L2 categorisation, because I think it's a bit problematic. So it's a distinction that's really commonly made. It gets made in the sociolinguistic literature, it gets made in the literature on learning languages. But I think what it does is it glosses a bit of the complexity of language acquisition and competence. Because we asked the people that we recorded to identify for themselves whether they would describe themselves as first or subsequent speakers of languages. And what that meant was that all of our Hong Kong professionals, who were a mixture of doctors and specialist nurses, all identified themselves as L2 English speakers. But actually, in terms of their competency and fluency in conducting those consultations in English, where English was the language that they chose to use, there was really very little difference between those and, say, the UK consultations that we had between people who were speaking English there. So where the differences that we really saw were in clients who identified themselves as speaking in a second language. And so it's this issue really about language use relative to context, because for those Hong Kong professionals, even very technical jargon or specialist medical terms was accessible to them in a second language. And obviously that was not necessarily the case for the clients. So to give you a quick bit of context for the findings, first of all. So in this particular corpus of consultations that I'm going to talk about, women are receiving unwelcome news. So they have undergone nuchal translucency screening and serum screening for fetal anomalies. And they have received what the services in Hong Kong deem to be a high-risk result, so something greater than 1 in 250. And so they've been called back to the clinic to discuss what they would like to do next in relation to that result. So as part of that, they're offered further diagnostic testing, which is amniocentesis usually in this setting. They're sometimes offered more detailed ultrasound scans. Or obviously there's always the option to choose not to undergo any further testing if that's what they choose. So professionals are really alert to the fact that this is a sensitive environment, that it's difficult consultation. They're really alert to language issues. And they spend quite a lot of time often trying to work out what a kind of common and comfortable basis to proceed will be. So if I show you one of the extracts, you can see what I mean. So I don't know if you can see that well at the back. I'll maybe just read it through. So on the slide, I've got the actual original Mandarin, in this case, utterances, and then the English translation below them. So D, in this case, is a doctor who's conducting the consultation. P is the pregnant woman. And the doctor starts by greeting the woman in Mandarin. So what the doctor has done is looked at the name and recognised that it's a Mandarin name. So the doctor says Mandarin, the patient says, yes, Mandarin. And the doctor says, I'm not fluent in Mandarin. And the pregnant woman, then says, English works too. And they agree that they'll speak English. So this is quite common at the starts of these consultations, that there will have to be this discussion about how are we going to manage this, what is the language that we can share here. The second thing I want to say is that we often conceptualise lack of shared first language as a problem, but there were also plenty of instances in the data where it was clear that pregnant women and their partners, or whoever else they came to a consultation with, were using it as a resource. So this is a couple who speak French as their first language. What's happened just before this is that the specialist nurse in this case has outlined what the future options are, and she's offered amniocentesis or a more detailed ultrasound scan. And you can see that they have a little backstage discussion in French about what they want to do, which the specialist nurse isn't party to, and then turn to the nurse and say, yeah, can you do both? So I think it's interesting to reflect on the fact that, you know, we assume that there are difficulties, but there may also be resources. But if I come on to kind of more central questions that we looked at, so does the presence or absence of shared language affect delivery of results? And what we found was that there was a common script for the delivery of results, which probably looks quite familiar to many of you. So it usually started by naming and explaining the components of the test that had been undertaken, because, as I said, there was both nuchal translucency screening and a blood serum screening. The numerical result would get given, so it would get given in a 1 in X format, but then usually that would be contextualised in some way for the woman. So practitioners would say things like a bit high or relatively high. And then they would come to presenting the need for a decision. And that kind of format didn't vary, dependent on presence or absence of shared first language. What did vary a bit was the way that the information was divided. So in linguistic terms, if we looked at those consultations, the differences were in the subdivision of the information. It was given in shorter chunks, what Silverman and colleagues might call chunking and checking. So shorter, simpler turn constructions with more checking in with the pregnant woman as the information was given. So then we looked at whether the presence or absence of shared first language affected the formulations that are used to present decision making, because obviously there are different ways that you can tell someone that a decision is to be made or can be made. And we didn't find any systematic differences in the way that decisions were presented across the three divisions of the data set. So across all of the categories, we found instances of offers of testing. Across all of them, we found recommendations for testing. And across all of them, we found option listing, so where practitioners would say, oh, you could do X or you could do Y. And quite often, those strategies would get used in combination and in different orders. So there might be option listing and then a recommendation for one of those options, for example. And what we didn't find, and what we were a bit surprised about, because the existing literature had suggested that there might be some issue here, was that we didn't find that the presence or absence of shared language restricted the range of formulations. It wasn't that one was more common in a particular group. So you might be thinking, well, this is not very interesting because all you've done so far is tell me things that aren't different. And so what I want to do now is talk about where we did find the differences. And where we really found the differences were in how pregnant women responded. So this was particularly the case in relation to recommendations. So in the absence of a shared first language, we found that the recommendations were received differently by women who were not conducting a consultation in a first language. And we found that the range of linguistic resources that they brought to bear on responding to those recommendations were very different. And if that maybe sounds a bit complicated, then I'll try and show you what I mean by way of an actual example. So I think this might be quite small, again at the back, so I'll read it through. So this is Cantonese on the slide with English translation. So again, it's a doctor in this consultation who says the chance of the baby having Down syndrome, it's about 300, just 1 per 350 people. Do you understand? Looking at the woman, so to speak, it's still relatively higher. So we recommend you to have amniocentesis. That means actually, and then the woman interrupts and she says, you've already considered it is probably not because of my rheumatoid arthritis. And the doctor says, I think this is not related then. So this is a shared first language consultation. They're both speaking in Cantonese, which they have both identified as their first language. And what you can see is that the recommendation gets presented, but it gets interrogated by the woman. So she receives the result, but she wants to talk about whether there are other factors that might have affected it, whether it can be taken at face value or whether her other medical conditions might have had some impact here. And she frames that quite tentatively. She does it with a negative polarity. So she says, it's probably not because of this. So she's orienting to medical or professional expertise in that way. But she's still interrogating the evidence. She's still got questions to ask about it. If we contrast that with consultations where women are using their second language, they show quite a different picture. And what we tend to see there are much more minimal responses. So again, I'll read it through. Again, this is a Cantonese consultation. This time it's a nurse, a specialist nurse and a pregnant woman. So the nurse says, the report turns out to recommend that you to have further investigation. The woman says, Nurse says, because you're now at 18 weeks, If you want to do further investigation, invasive investigation, then you would have to take amniocentesis. That's it. It's only a recommendation. To do it or not in the end is decided by you and your husband. So that is a very typical example of how recommendations are responded to by women using second language in our corpus. So you can see that the professional is at pains at the end of this consultation to be very clear that this is a choice to be made. She says this is only a recommendation. To do it or not in the end is decided by you and your husband. But you've got this pattern of very, very minimal acknowledgements from the woman herself. And so those two extracts really show a pattern that's very common across the data set, where recommendations are made to women who are using their first language. They engage with them, they talk about the certainty, the reliability of the test and so on. They're much less likely to treat them as definitive, and that means that they don't necessarily go along with the recommendations. Where women are using second language, they're much more likely to produce the kinds of minimal responses that I've just shown you, and they're much more likely to go along with what's recommended. And what my colleagues and I would argue is that that's because resisting a recommendation is actually interactionally quite a difficult thing to do. It requires quite sophisticated linguistic resources because there's what sociolinguists would call an interactional preference to accept a recommendation. So ordinarily language is organised in ways such that we minimise conflict. So if somebody asks us to do something, we do it if we can. If somebody gives us an instruction, we follow it if we can. If somebody makes a recommendation, the preferred response to that is to accept it. And if you're not going to accept it, you would normally provide an account for why you're not going to do that. And that's difficult for people in a language that is not their first language. So we then thought we would look at what happened when alternative approaches were used. So recommendations were common in our data, and that is a feature of the service in Hong Kong. But they weren't the only format that was used, as I said. So we also looked at what happened when offers were used, and that showed quite a different pattern. So this, in the interest of time, I'll just show you second language consultation here. This time it's a doctor. And the doctor says, so it's up to you. We still call it screen positive because there is a small possibility that the baby may have Downs. Pause from the patient. The doctor says, but it's up to you whether you want the amniocentesis to check if the baby has Downs. And the woman interrupts and says, is it the one that put inside, referring to the way that the test is done? Doctor says, yes, while nodding. And the woman says, I've discussed it with my husband. He says he doesn't want. The doctor says, right, while nodding. And that woman goes on to decline the amniocentesis. So linguistically, again, if we think about this, the thing about offers is that they require an active expression of choice. And so what they do is provide a space for somebody to articulate their viewpoint. You can't agree minimally with an offer because there is no way to do that interactionally. If somebody says, you can do this or not, you have to form a decision about which of those things you will do. And what we also found in our data was that option listing, which doesn't conclude with a recommendation, so option listing which just says you can do X or you can do Y, fulfills that same kind of function. So I guess there's something quite important to say here, which is that I've said there's a pattern of minimal responses where recommendations were used in our data, and there was a pattern of women then going along with the recommendations. Of course, it's important to say that when we see those minimal responses and people going along with recommendations, it doesn't necessarily mean that they're having their decisions determined for them, because that might have been what they wanted to do all along. But the problem is that we can't tell whether they're exercising choice or not, that the practitioner can't know whether that was an active exercising of choice or whether it is going along with a recommendation because linguistically it's difficult to resist. So just some conclusions, just to sum up quickly. I think the first thing to say is that professionals in this context are really sensitive to the contingencies, to the difficulties of communicating with clients who might be using a second language. And certainly in terms of how they structure the consultations on a foundational level, they try really hard to be sensitive to that. So whether a particular action is promoted or how strongly it's promoted certainly doesn't appear to correlate with L1 or L2 use. And that's interesting because there are some suggestions in data from other settings that where clients are using a second language, health professionals are likely to be more directive. And we didn't find that. But what we did find is what I've just shown you, that it was not overt direction, but that we found women much more likely to make those minimal responses and end up going along with the recommendations. So it wasn't an intentional part of the delivery of the service, but it was something that happened because of the way that language was used. And obviously, women using their first language did sometimes go along with the recommendations. But as I hope you saw from one of the first extracts I showed you, they did that with much more active involvement so that you could see the decision-making process happening. So just some quick implications of that. So for practitioners in any setting who want to maximise engagement, in decision-making, recommendations might not be the best way to do that. And I know on the one hand that might sound obvious, but on the other hand I know it's really hard, because when clients are trying to grapple with information that they're finding difficult to assimilate or that they don't have an existing knowledge base for, they very often ask for those recommendations, or they very often ask questions like, well, what do most people do? Or what would you do if you were in this situation? And so I guess I'm just highlighting that it's something to be aware of, that resisting a recommendation can be really interactionally difficult. So I said that there was some existing work on the way that direction is more common in second language consultations. And it's been argued that this is because while you may have everyday competency in terms of carrying out actions or accessing services in a second language, what's really difficult for speakers of second languages is being able to represent yourself, being able to represent your feelings and your views. And that's why it's particularly difficult, or that's why it can be particularly difficult to resist something that's presented as a preferred course of action. And so on that basis, offers of testing or option listing that doesn't conclude in a recommendation is probably a better approach if you want to be able to observe active decision-making in a setting. And then the last thing to say is just, is more of a methodological point, is just to flag again that what the research also showed was that the L1, L2 distinction that often gets used to underpin research in this area, it doesn't map practically really to the way in which people use language and how professionals in particular may have very sophisticated vocabularies across both first and second or subsequent languages. So thank you for listening.
And so our next speaker is Dr. Ed Miller. He's an education specialist for the Genomics education programme with Health Education England. He's got a PhD in DNA damage and repair. And so is a researcher with experience in science communication and public engagement. And he's currently leading several projects to support education and training to embed genomics into mainstream practice, with a particular interest in nurses and midwives. So I'll hand you over to Ed.
Is it green button? Okay. Good morning, everyone. Make sure we're... There we go. So thanks very much first for the invitation from Annette and Vicky to talk to you today. And for the next 40 minutes or so, I'm going to talk about the programme which I work for, which is the Genomics Education Programme, which is part of, or works within Health Education England. But I thought I'd just start off, and it's really been covered where we are, I guess, in terms of genomics within the NHS, but just really to drive that message of almost sort of where it started and where we are now. But that's not to ignore the fact that genetics has played a massive part in the NHS for many years, over 50 years really. We've been looking at DNA or an individual's genome to be able to inform care. But in terms of the drive of genomics, where we're looking at all an individual's DNA, this was really kick-started back in 2012 with the 100,000 Genomes Project. And what the 100,000 Genomes Project was, it was I guess a proof of concept project to really demonstrate the benefit that whole genome sequencing, so looking at all an individual's DNA, could bring to patients with cancers and rare disease. And this was delivered through the NHS, so using NHS patients. And what the project did was it established pathways, it identified roles, it created infrastructure. And whilst this project was running between 2012 and 2018, there are a number of high-profile reports that came out as well, really emphasising the impact that genomics would have on care. And then at 2018, where the 100,000 Genomes project effectively came to an end, NHS England launched the Genomics Medicine Service. And this is where we are now, being delivered by the 7 GMSAs across the country. And again, the idea of the Genomics Medicine Service is the offering, or the equitable offer, of genomic testing to all of the population within England. So with this move of genomics then, out of kind of specialist services and more into routine care, genomics will to some extent impact on many NHS healthcare professionals. So they will all need to have some understanding of what genomics will mean for them and those in their care. However, not everyone needs the same knowledge and skills to be able to do this. So this here is just a simplified patient pathway, and along the way, I'm sure there's sort of points there where you can identify where you might interact with that individual, and any one of those points that patient may want to talk to you about the genomic testing they're going through or the results of the genomic test they've just had. And just further to emphasise the shift of genomics into routine care, this has also been reflected in education and training. So I've just highlighted a number of reports. So in the NHS People Plan, it emphasises that this will drive further workforce development and new education and training approaches to help embed genomics. Genome UK, which was launched back in 2020, which was launched by the Department of Health, and that was really setting out the vision over the next 5 and 10 years of genomics within the UK in terms of healthcare, research, and also academia. And then more recently, back in October, NHS England released their first ever genomics strategy, again, sort of really mapping out the impact that genomics will have, and again, emphasising the importance of education across all healthcare professionals and across all sectors within healthcare. And furthermore as well, the importance of genomics within healthcare has also been reflected in standards as well. So the first standard, I guess, genetics has always been in there, but really it's this change of this word from genetics to genomics, was the inclusion of genomics in the nursing standards back in 2017. This was then followed by midwifery standards, but also genomics is in the nursing associate standards, and then very recently the standards for specialist community and public health nurses. So you're really seeing now genomics is starting to appear not only out there in the service as well, and increasingly more, but also now there's a requirement within educational standards. So this is where our programme comes in. As I said, we're part of Health Education England. We're a national programme. And the Genomics Education Programme, we were established back in 2014, and at that time, we were created really to support those individuals within the NHS who were working to deliver the 100,000 Genomes project. So very much focusing on the specific pathways and their particular processes in delivering that project. And kind of bubbling underneath that was this larger remit of engaging and producing education and training for the wider workforce. Then, as of 2018, when that project effectively came to an end, we became part of Health Education England as business as usual, so we're a national programme. And now really our focus is to ensure that all NHS professionals have the knowledge and skills and experience to deliver genomic medicine for patient benefit. And when we talk about all NHS professionals, we're talking about all. So this is those working out in clinical practice, but also those who might be working in administrative roles. We're really there about creating awareness about genomics and what it means for those working within the NHS. And because this is such a large audience, obviously we are trying to engage with a variety of different individuals, so across different professional spectrums, from nursing associates through to senior consultant, and at various different stages as well in their education and training. And as I mentioned, our initial focus was very much around the 100,000 Genomes project, but now really we're supporting with our colleagues in NHS England and beyond the rollout of the Genomics Medicine Service. And how do we achieve this? Well, we have kind of 4 key strategies, really. The first is identifying workforce needs. What is it that the workforce needs to do or need to understand about genomics to be able to carry out their role? The second is to educate and develop the NHS workforce. So this is through the provision and creation of resources tailored to the needs and interests. This is very much around proactive, but also reactive learning as well. So proactive being those courses that you may, or education that you may have to take more time to engage with. Proactive is that just in time, you know, getting that information as and when you need it. We also do a large amount of awareness raising, so increasing awareness of genomics across the whole healthcare spectrum, working with our networks really to demonstrate the importance that genomics will bring to patient care. And then lastly, a big part of our work is also building and joining networks as well. So ensure that we have this national coherent approach, that we're all talking the same language, we're all supporting each other, and we're having a consistent approach to the education and training across the system. So I'm going to go through each of these really and give you some examples of how we do this within the programme. So first off, identifying workforce needs. And we do this broadly in two ways. Quite often it's a top-down approach. So this is where we're having sort of high-level instructions. I shouldn't call it that sounds too official, doesn't it? To meet urgent needs and gaps. So this is, you know, for instance, around the Genomics Medicine Service, and that's driving the production or driving our strategy or what we're doing. We also then do a consultative approach, which is allowing the workforce themselves to define their own learning needs and styles, so engaging with those that we're trying to educate. So to give you an example of how we're looking at identifying workforce needs, and Naomi and Annette have both talked to this, is our Clinical Pathway Initiative. And the idea of the Clinical Pathway Initiative is that it's to introduce a unified approach to the integration of genomic medicine across different specialties within healthcare. It's also there really to identify workforce development and educational needs, and also to help to harness and share expertise across the country, to avoid duplication, and this is something that we really, you know, we keep on sort of singing as our mantra. It's a kind of to do once and share, and also to provide a bite-sized clinical relevant approach to genomic medicine. And it's competency-led rather than professionally led, because we know that different clinical pathways are delivered in different ways across the country. So we need to make sure really what we're focusing on here is the education and training needs, and not how the particular pathway has been specifically delivered in that area. So apologies for the crudeness of this, but I've had to do some cutting and pasting to make it fit on the slide. But this is just an example here of one of the CPIs that have been developed. So on our website, we have a template if you choose or wanted to map out a pathway. And the idea being is that it's high level. So you would identify a particular pathway that you wanted to look at. So in this instance here, this is a familial hypercholesterolemia clinical pathway. And the first step really is to break down that pathway into its constitutional steps. And this could be either broadly where you're looking at identifying patients and requesting tests and then returning results, or it could be the whole sort of pathway in itself. And you can see here the individual steps have been identified. Then following that, it's the identification then of the competencies that an individual would need to have to be able to deliver that particular step. Then following on from that, the resources then that are aligned to those particular competencies, or resources that can support those competencies. And then lastly, identifying which member of the workforce would be carrying out that particular task. And really, the benefit here is that obviously, by keeping it high level, what we hope is that it has adaptability. So it can be used by other services as well. So we want to make sure that there are going to be common steps as well that can be shared, but it's not specific to the particular pathway where it's been developed. So what it isn't really is it's not a patient pathway, and it's not telling you how genomic medicine should be delivered. It's not adaptable, it's not set in stone, it's there as a template, it's there as a support method. So what it is it's a step-by-step method to identify the workforce and development and education needs, aligning these to patient pathways across the Genomics Medicine Service. And as I mentioned, it's very high level, and it's an overview of the clinical pathways, and it's adaptive and it's flexible. So we have about 17 of these currently in train and being developed. Our kind of ambition, and we have a lot of ambition in this program, is to actually have CPIs that reflect all the test directory entries within the National Test Directory. But that's obviously a long way off. Another way of identifying and looking at workforce needs is through competency frameworks. And we do this in two ways, really. So in a profession agnostic, so we have competency frameworks on our website that are not profession specific, but they're based around particular aspects of the genomics medicine service, so return of results or consenting for genomic testing. But we're also trying to focus on more profession specific. And the example here is a nursing competency framework that we've been working on for a couple of years alongside with colleague Emma Tompkins, so working very closely. And the idea of the competency framework is that the one that we've been developing has been building on previous work that was carried out by Maggie Kirk et al. Back in 2010 and published in 2014, and previous to that, 2003. And the competency framework, what we hope is really, it's there for the current and future workforce to reflect on a modern genomics medicine service. So hopefully outlining those core competencies that all nurses will need to be able to deliver genomic medicine. And we developed this via a consensus method, which was overseen by a steering group with representatives from nursing education, policy, and practice. So this is just to give you an overview of the process and how we did this. And this was adapted from, so the competency framework that we've ended up with is based on the competency framework that was revised back in 2010, the work I described earlier, which was developed back in 2003. So it's really been a kind of an evolution of an existing competency framework. And how we came to the draft that we currently have was we used clinical scenarios. So we developed a series of clinical scenarios that were either real-life case studies or based on real-life patient stories or anticipated future service. And then we gave that to a consensus group, and we asked them first to identify patient needs, and then what would a nurse need to do, think, and behave to be able to meet the particular needs of that patient. And then we collated these responses and we mapped those back to the existing framework to see if there was a need for any additions, any rewording, any omissions. And then we put those findings back to the consensus group where we did a series of votings on the findings that we had from the first part of the exercise. And this then produced the draft, which we put out for consultation, and that closed a couple of weeks ago. And this is the stage that we're at now. So we have all that information from the consultation, and Emma and I have got a lovely job now of pulling that all together. And a really, actually, a crucial bit of work where we want to finalise the competency frameworks, but add that detail that's needed as well, that description of how these competencies can be used, who they can be used by, and again, how they were developed. And this is just, I guess, just briefly, I wanted to put this up here because what we found that was really interesting about the outcomes of the competency frameworks is that a lot of the, I guess, competencies that are identified were those that are really kind of nurses' bread and butter. You know, things around identification, tailoring information, communication. And there are only a few really that were kind of had that genomic angle. And this is just the case studies that we used. And what this is showing that over the 8 competencies that we have, you know, there's a tick for pretty much all of these different competencies throughout the case studies. So that was really, really encouraging, actually. And in terms of, and it also complemented the previous work that Emma and her colleagues had done around the competency frameworks, that really it was still singing to those kind of core competencies that nurses have. So where do we see these competencies being used? Well, this is a heat map, and what the blue indicates is level of, I guess, of genomics knowledge. So here we have sort of specialists, very specific genomics knowledge. So this might be a genomic clinical nurse specialist or a nurse specialist working in a particularly genomic-heavy clinical pathway. And then moving across, you can see here to kind of less genomic knowledge. But what's interesting to point out, really, is that, you know, what this is showing here, that even if you're working maybe at a high level within the career, at a nurse consultant, depending on where you're working within clinical service, you may only need a limited level of genomics knowledge. You might not need that real detail. And therefore, I guess where we are kind of looking at where these competencies will sit is around here. So building on this pre-reg foundation knowledge, so genomics has been delivered in the pre-reg space, and then really it's covering this, I guess, baseline knowledge. And then obviously moving then into more specialist roles, what we hope is that the competencies could be used as a foundation or a springboard to developing more specific competencies for particular clinical areas. And we're now looking, I'm aware this is nurses, and unfortunately a couple of the examples I will be giving will be focused around the work that we've been doing with nurses, but there are plans in train at the moment to produce a competency framework for midwives as well. So on to our next sort of strategic aim is to educate and develop the NHS workforce. And our programme develops many different educational resources, and really what we try and do is cover the burner kind of novice to expert spectrum, although in some senses as well, we're not saying that this is kind of the natural progression, because some people will just be happy at the novice and some people may want to be the expert. So really it's what we're trying to do is make sure we're covering all these different aspects from novice to expert in the educational resources that we provide. And starting at the novice end, we have bite-sized information, so we have very short, snappy, I guess more just-in-time information around genomics and what it may mean for care. Moving through to short e-learning courses, so we have a Genomics 101 series that's available on e-learning for healthcare, and that's free for any NHS professionals, and in fact we've now given those open access, so anyone can access these online courses. And the Genomics 101 were really designed for those with little to no knowledge around genomics and taking you from some of that fundamental science through to the more clinical application of genomics. Then moving up into resources more specifically around the Genomics Medicine Service, we have courses on FutureLearn, so massive open online MOOCs. And in fact, yesterday we launched a MOOC around rare disease pathway and ordering genomic tests within the rare disease pathway, so that's now live on FutureLearn. And then moving on to more formal learning out of our Masters in Genomics Medicine framework. And this is one of the oldest initiatives within our programme. It was started back in 2015. And the Masters in Genomics framework is delivered by 7 partner universities across England. And the way that this is offered is that initially you can take a specified number of modules as part of either a PG Cert or a PG DIP, or you can take individual CPD modules, and then if you have evidence from your line manager that how are you going to use that knowledge and want to go on for further training, you can take the whole Masters. And HE funds places on the Masters as well. I should mention as well, running along the bottom, is a very large piece of awareness raising, and this is very much around videos, blogs, and we're very active on social media as well. So just to give some examples of the education that we do offer, we have a curated page on our website which talks about learning journeys, where really we sort of identify those resources that we have depending on where you might be, say, on your genomics learning journey. So apologies, you probably won't be able to see this, but this really, the first section here is talking about those that are new to genomics. So we have a bite size on what is genomics. We have very short animations around what is DNA, what is the genome, etc. We have fact sheets as well, and also a glossary. Moving on from that, if you want to then learn about the fundamentals, as I mentioned, the Genomics 101 courses, we've 9 of these available on eLearn for Healthcare. And these really start to take you through some of the fundamentals around genomics and also its application within medicine. And then lastly, to begin starting to understand what genomics means in practice, we have Genomics in Healthcare as a course as well. We have things around taking a family history, communication around genomics. So what we kind of hope is that really that you can see the path of learning if you want to learn more about genomics through the educational resources that we produce. We also have web pages on our website, obviously, because it's a website, but web pages that are focusing on particular professions. So we have a Genomics in Midwifery web page, we have a Genomics in Nursing web page, and also we have a Genomics in Health Visiting. And these very much hone in on the particular profession and also focusing on what genomics means for that profession and also educational opportunities as well. We also have web pages that look at particular clinical specialties. So we have a web page around genomics in cardiology, oncology, and neurology, just to name a few. And on these, what we do is try and demonstrate how genomics is going to make an impact, and we hear from experts within these fields on how genomics is making an impact on their particular clinical area. And one just to mention quickly, and it's been mentioned earlier today, is GNotes, which is one of our very new resources as well, which stands for Genomic Notes for Clinicians. And the idea here is that it's a two-tier resource of just-in-time information. At the moment, it is very clinician-focused, but me included are really trying to push this forward to make it more multi-professional. And the idea being is that the two tiers exist in a way that you have tier 1, which is your just-in-time information. If you're in clinic, you might be presented with a particular situation. You could go on and have a look at these tier 1 clinical situations. And then underpinning the tier 1 is the tier 2, which is our knowledge hub. And this has all the relevant resources and information to be able to support the information that's being delivered in tier 1. It's free to access by all NHS staff, and it's a collaboration between us and the Academy of Medical Royal Colleges. And currently, I know there's a fetal maternal group that's forming to develop GNotes. And obviously, we're pushing, and from the work that's happening in the transformation project, this will help inform as well the creation of GNotes tier 1 resources that are reflective of nursing practice as well. So just one other resource to mention in the education. As I mentioned earlier, genomics has been now included in numerous standards, both the midwifery and the nursing associate, and also in the community specialist community nurse standards as well. And this led us to develop a resource, an educator's toolkit for nursing educators, particularly for the nursing standards. And as you can see, the way that genomics is being included in these standards is it is just essentially a word. There's not really much context around it of how much genomics to teach or what actually that means for practice. So we have an educator's toolkit on our website, and the idea here is that it's to support educators, both in the pre-reg but also in the post-reg space as well, with the incorporation of genomics into curriculum and education. And what we really wanted to make sure with this toolkit is to demonstrate that genomics isn't a standalone subject, which often is the way it's perceived. It's a specialist subject. It's often delivered in the undergraduate space as kind of a one-off lecture, maybe even in the first year. It's very sciencey. But we wanted to show that genomics isn't that. Genomics is moving out now and obviously is finding its way into many other areas within healthcare. And then it could be knitted throughout curricula. And it has applicability to different levels of teaching, nursing fields, and areas of practice. And our approach to developing the toolkit, initially we were very much thinking this needs to be very prescriptive, with lesson plans, with assessment questions, but actually through conversations with our working group that included nurse educators, what we really found, and I think what was really needed, was case studies to show that relevance of genomics to practice. What does it actually mean to bring it alive? So the toolkit is case study based, and the case studies are categorized by nursing field, they're categorized by nursing activities, so those activities, again, that are kind of very familiar with nurses, so identification, communication, and management. They're categorized by area of practice, so it may be rare disease or cancer, and they've also then been mapped to the NMC platforms and outcomes. And then each case study is then supported by additional kind of teaching moments, but also discussion points as well, again, to help educators use those case studies. And they're very kind of detailed and rich case studies as well. They're not just focusing on the genomic element, to really bring them alive and incorporate them into their teaching. So when I say that we've mapped these case studies to the standards, what we did is an exercise where we sort of looked at all the NMC standards for nurses, and what we tried to do is, obviously there are the two places where genomics is mentioned specifically, but we wanted to then look across all the standards and see where, okay, well, where would genomics, really apply? So, for instance, here in Platform 1, being an accountable person, one of the outcomes is to understand the need to base all decisions regarding care and intervention on people's needs. And really, we, putting the genomic slant on this, we put that if genomic condition is suspected, consider impact on family, culture, religion, prior experience, and personal values. So really to show that genomics, it isn't all about the science and it isn't all about the testing. There's so much more to genomics and that can be brought into the educational space. And this is just a quick overview of how the toolkit looks on our website. So this is one of the case studies, and the case studies have been chunked up as well, so they're in more sort of digestible pieces and broken down with headings. So we've got identification and diagnosis, treatment and management. And then each case study comes with this at-a-glance information, and what that does is tells you the clinical focus. So, for instance, this one is cardiology. It tells you the nursing activities that are identified within the toolkit, and then which of the NMC platforms and outcomes that particular case study is aligned to. And then at the bottom, we have teaching moments and discussion points. Teaching moments being more about that knowledge application, and then discussion points, I guess, the application, bringing these stories alive and creating discussion around these particular situations. And again, we're looking to develop equally the same for midwives as well. So in terms of increasing awareness of genomics across healthcare, this is something as a program we can constantly do. We hold webinars and expert webinars, so we've worked with the RCNI to, I think a couple of years ago now, in collaboration with our colleagues in NHSE, to create a series of webinars, again, around genomics. We have expert webinars that we're developing at the moment as well. And also each year we run a week of action, which is our hashtag Genomics Conversation, where we sort of focus on one particular week in the year. So now we run it in June, where we either look at a particular topic around genomics or we focus on a particular profession. So last year, our genomic conversation was around literally that, conversations. Where might you have conversations around genomics within practice? Our next week of action is in June next year, and the focus there is looking, or our tagline is hidden genomics. So that's thinking really, well, where else might you encounter genomics within your practice in those kind of unexpected places? Because really, what we're trying to find are those hooks and those ways in to engage with the workforce and demonstrate how genomics is going to be impacting on practice. And then lastly, how we build and join our networks across the country. We're a relatively small team, although we seem to be expanding at a rapid rate at the moment. So we're about 20 of us in the team, but we can't do this alone. 1.2 million staff within the NHS is a big remit. So we are constantly, our door is constantly open to engage, build relationships and work with our stakeholders. And these include our colleagues in the GLHs and in the GMSAs. We've got primary care networks, we work with universities, we work with external networks, so the NHS England Genomics Unit, we work with Genomics England, Academy of Medical Royal Colleges, charities, patient groups. And all our work is making sure that what we're delivering, it meets the requirements of the system, is constantly being informed by the strategies that are being released on a year basis at the moment, really. And I just wanted to highlight a couple of examples of how we sort of build and join the network. So we co-chair a joint workforce steering group that really oversees genomics and how it's impacting on care and bringing that educational element to it. We have some fellows working with us and the Academy of Royal Colleges to really engage with the Royal Colleges about genomics and embedding it in curricula and education and training. We work very closely with Macmillan, so we have a fellow working with Macmillan who we co-fund, again, to focus on producing educational resources for cancer nurses. We've worked with the Institute for Health Visitors by producing a set of good practice points around genomics. And in terms of universities, obviously we have our MSc framework that's delivered by 7 partner universities. And currently this is going under a review and also an evaluation, really, to make sure the content of that framework is really fit for practice. And what we're delivering in that Masters is actually reflective of what's required out in the system. And then also we've provided funding for places on a course that's delivered by the University of West England that was created in collaboration with us and Macmillan and NHS England that's called Genomic and Counselling Skills for Nurses and Healthcare Professionals. And this is growing in size, and they're looking to kind of future-proof this and roll it out. And this is a remote course as well. And that's what we try and promote with a lot of our formal education that we support, to make sure that there is availability across the country. But there are ongoing challenges. There are real challenges, that we're still trying to get the message out there about genomics, and we're constantly finding new ways or innovative ways or creating new networks to be able to do this. And often the challenge can be is like, how much genomics do people need to know? That can be quite difficult because the service is moving and changing so rapidly. It's often quite difficult to pluck that perfect example out of the sky to demonstrate how genomics will impact that individual. So that demonstrating the relevance to practice is a real challenge. But as I said, as genomics becomes more embedded in healthcare, what we hope now is that more case studies and more examples will become available to really demonstrate the impact that genomics will have on care. Equally as well, there's a lack of confidence and experienced educators out there as well. So it's all very well that maybe if genomics is being delivered well in the undergraduate space, but then if those individuals are going into care and they're not sort of being supported by confident sort of practice educators or those that are supporting their revalidation, etc., then that's also a barrier as well. And as we know, those in practice, there's still a large number that we need to engage with as well. And then also time to learn. Genomics isn't the only thing on nurses and midwives' plates. There's a lot of other things going on as well. So it's finding that balance, it's finding that way in, it's finding that hook to make genomics more palatable for nurses and for midwives. So I just wanted to leave you with a few final thoughts and take-home messages. And this is kind of, again, it's been mentioned earlier today, but just by talking to your colleagues around genomics, talking to your colleagues that you've been here today, just starts that conversation, starts people thinking. There is a lot of information out there. The GMSAs are doing great work. There's information on our program. But just to begin that genomics conversation, because it's happening and it's happening at pace, and really we need to make ourselves feel confident and be reassured that we know that what genomics means for our own practice and those in our care. You could take one of our Genomics 101 e-learning modules. They're there, as I said, they're free, they're short, they've got quizzes in them, and you can get a certificate at the end. Or you may even have a patient story. If you do have an example, come forward. You can contact us, you can contact your colleagues in your GMSA as well. But share stories. Again, hearing those personal experiences or using those personal examples, we found with education, they are key, really, and that's what nurses and midwives want to hear. They want to hear those examples. And always try and think genomics. It may not always be that obvious, and that kind of falls back to the point about our next week of action, hidden genomics. It's not all about the specific test. What's going on around it, what's going on within the family. There's things around communication, support, ongoing management. And I feel really bad because this has kind of stolen the Annette's idea at the beginning. So what does the word genomics mean to you? So I've taken this from an educator's course that Emma and I ran with a colleague, Amanda, back in July this year, I believe it was, around genomics. And we asked the question to those that attended, what does the word genomics mean to you? And this was at the beginning of the workshop, which was a 4-day workshop. And you can really see that, and I hope I'm not kind of predicting, this shouldn't influence what you want to say at the end of, if the question's asked again. Is it? Oh, that's good. Whew. Okay. So you can see it's very sort of science heavy. It's DNA, it's genetics, it's genes. And then at the end of the workshop, we asked the same question. And what we found, it was a lot more rich, the responses that we were getting, and it was really reassuring. And really that's, I guess, the point I'm trying to make about thinking genomics. It may not always be that obvious. So, ethics is in there. We've got conversations. It's important, responsibility, quest for diagnosis. So it's really sort of thinking more broadly about genomics and everything that's going on around genomics and trying to sort of take the fear away from that complex word that maybe is associated with science. And I'll leave it there. I'm happy to be contacted if you want to get in touch, want to ask any questions, but also if you have any ideas of any resources or work that you are doing that you want to share. And there's our website address, and we've got a stand, well, I've got a stand at the back with some leaflets as well, should you want to take them. But thanks very much for listening.
Epilepsy. So without further ado, I will welcome to the stage our first speakers, who are Vicky Kiesel, who is the lead genetic counsellor at the L&R Genomic Medicine Service and is the lead for Lynch in the East Midlands area. And she is joined by Leanne Barrett, who is... Leanne. I'm looking at this. It says here that you're the next band marketing manager Yes. Yeah, okay, that's fantastic. And you are obviously here as our patient, to give our patient voice about the experience. So thank you very much for joining us. Thank you. So I will hand over to Vicky.
Perfect. Thank you very much. So hopefully I can work the IT. Stop me at any point if you have questions. Don't wait till the end. It makes much more sense as we're going through. So, okay, fantastic. That's a good start. So we're going to talk about Lynch syndrome. It's basically a warm-up for Leanne, who will give you much more interesting and pertinent information, I expect. But this is about the pathway that we've been setting up across the East Midlands. So I'm going to start right at the basics. So if you know all of this, I'm sorry, but just to make sure everyone's on the same page. An estimated 175,000 people in the UK have Lynch syndrome, which means over 1 in 350 people are affected. But more than 95% of people with Lynch syndrome don't know it. And it causes approximately 1,100 colorectal cancers a year, meaning that it's responsible for about 3% of endometrial and colorectal cancer. So essentially, this is actually relatively common, and we don't know about these people, so we can't help their families as we should do. There is a test that should be done on all tumours called immunohistochemistry that looks at the 4 proteins that should be there if the patient doesn't have Lynch syndrome. I'll explain more about the science in a moment. So the risks of Lynch syndrome. If somebody has an inherited risk to colorectal cancer that's caused by Lynch syndrome, their risks vary significantly. But the risk of colorectal cancer can be anywhere from 10 to 57% in their lifetime. And this is altered significantly by the gene, age, and gender of the patient. The next most common cancer is endometrial, and the risk is anywhere between 13 and 49%. And this can be much higher depending on the gene again, and obviously if you're a female you have this risk, if you're a male you obviously don't. Gastric cancer is another cancer that we look for, and this is another one that we actually have positive things that we can help with. There are bacteria that we can screen for and eradicate and lower individuals' risk of gastric cancer. Then there are lots of other small risks of cancer. Most of these we don't do screening for at the moment, although there are studies in place and we're learning more about them. So this is showing you a little bit about the gene-specific nature of the cancer risks. So the highest risks of cancer are seen in men with MLH1 and also upper GI, so stomach and that sort of thing, while MSH2 females have a relatively high risk of endometrial and ovarian cancer, and men with MSH2 specifically have a risk of prostate cancer, which is one of the newer things that we've been discovering. We weren't originally aware that prostate cancer is linked to Lynch syndrome. We know that it is now. Gemma's going to talk after us about prostate cancer. And then MSH6 and PMS2, these 2 genes are lumped in with Lynch syndrome, but the risks are a lot lower, and they're a lot more cancer specific. So somebody with a PMS2 gene mutation may have a very slight family history. They may not develop cancer themselves, their relatives might not, but they do still need screening, not to the same degree as MLH1 and MSH2. So as I said, 95% of people with Lynch syndrome don't know they have it. So they're not having colonoscopies, they're not taking aspirin, women aren't given the options to have risk-reducing oophorectomies and hysterectomies. The crucial thing with cancer prevention is knowing that somebody has a risk. So that's why this is so important. Oh, and the other point there was, even if somebody knows they have Lynch syndrome, historically, they haven't been managed optimally. There's lots of work happening at the moment to make sure that everyone with Lynch syndrome gets their colonoscopies and gets the screening that they need. There's a massive national push for this. So in order to try and identify everybody with Lynch syndrome, in 2017, they decided, the powers that be, that every colorectal cancer needs to be screened for Lynch syndrome. And then in 2020, they decided the same thing about endometrial cancer. This was quite patchy, and again, another reason why we've done this project, to try and make this more uniform across the country, and most importantly, to make sure it's actually discussed and actioned. So, stop me if at any point I don't make sense. Somatic testing for Lynch syndrome. There are 4 genes that specifically increase the risk to Lynch syndrome, that cause Lynch syndrome. If there is a mutation, an alteration in one of those 4 genes, then it causes the proteins to be missing. So, just to start from the beginning, a gene causes a protein does something particular in the body. Some of these proteins prevent us from developing cancer. So if the gene's not working, the protein's not present, people have an increased risk. Does that make sense? You can say if it doesn't. Okay. So the first test that people do is immunohistochemistry. It looks to see if the proteins of these 4 genes are there. If the proteins are there, people probably don't have Lynch syndrome. If the proteins are absent, they might have Lynch syndrome. It's not a black and white test. The gene products can be absent, and that can happen by chance. But it's our first test, it's the first stage, and it leads us into the next steps of testing. So 30% of endometrial cancer, by chance, will show absence of MLH1 and PMS2. That's why the second step is so important. And with colorectal cancer, it's 15%. So there is another step of testing done on the tumour. Once all this testing is done, then we indicate to patients whether or not they want to have germline testing. So the other important thing is even when these tests are done, so you've got your immunohistochemistry, the first step, you do your second step, which is either BRAF or methylation. You've decided this person actually is at risk of Lynch syndrome. Audits have shown a third of those patients are actioned, the rest are not. So you have these results in somebody's medical records saying they're potentially at very high risk of having Lynch syndrome, which influences their risks and the family history's risks, and no one's ever done anything about it. So part of our project is actioning this, is making sure that the MDTs have to discuss these results. Every patient, they have to go through and say, what are the IHC results? Have they been performed? Have the next steps been done? If necessary, are they referred? So it's really important, obviously, that this happens. And NHS England are very enthusiastic. They've given us lots of support for this. There's a lot of emphasis on this. The operational guidance for 2022 to 23 is a massive focus on Lynch syndrome. I'm not entirely sure how that happened. I think some of the leads in London were very forceful, but it's really good. So this is the pathway. As I said, every new diagnosis has IHC. Depending on the results, they either have hypermethylation or we're told that they're not at risk of Lynch syndrome. Or if there's a specific gene pattern, they can go straight for genetic testing. And this is just the same pathway with endometrial. The only difference between endometrial and colorectal is that the second stage is slightly different. You don't do BRAF for endometrial. Any questions so far? I know it's straight after lunch and you probably would rather sleep than listen to me. So the pathway is supported by lots of different people. In the East Midlands, we're really lucky. Our Cancer Alliance is really engaged, so EMCA is really helpful in supporting us. Sally Pitkin has been really enthusiastic. Obviously, we've got the GMSA, the Genomic Medicine Service Alliance. There are, as I'm sure you now know, there are 7 in the country. We're the East GMSA. I can see people nodding about this morning's lectures. And then we have the National Genomic Test Directory, which in theory means that it should be the same across the whole country if your laboratory is able to provide the service. And that's just showing you some of the test directory criteria. So germline testing is needed if IHC shows absence of MLH1 and methylation, or if there's absence of any of the other 3 genes. So the way to remember it is MLH1 means second steps, no MLH1, go straight for germline testing. You don't need a family history questionnaire. So if you see these people in your clinics, the only thing that matters to us at this point is the IHC results. If they have got a family history, then that's interesting and important on a separate note. So in future, all patients with IHC, abnormal IHC, will be discussed in the MDTs. We're going into every MDT in the East Midlands to make sure this happens, and we're talking to the databases that document this to make sure that it's documented. Germline testing hopefully will occur in MDTs. So I don't know who here is in an endometrial or colorectal MDT. So one brave lady at the front, you're going to be doing all of this. Amazing. So you're endometrial then, if you're doing BRCA? Excellent. So, oh, I can see somebody else is also. Yeah, colorectal. So we're doing MMR testing, but we're just setting up MDT. That's good. That's actually happening. So the testing is taking place and you're having the conversations. That's the most important thing. For years, this hasn't been happening anywhere, so it's good. Eventually, these nice ladies in MDTs and anyone else, we are hoping that they'll be able to do the germline testing straight away in the MDT so that people diagnosed with cancer don't have to wait 1 or 2 months to get to see us in genetics and can be seen straight away and tested there and then. But we'll be there to support everybody. One of the crucial...
Okay, that's one of the things that we're starting to build up now is to do the counselling and to actually see patients with the MMR deficiency. we were planning on doing the family history questionnaires or giving them to them. Would you not recommend that?
I would ask them about their family. Thank you. Can I ask where you are from?
Northampton.
Northampton. Yeah. Oh, okay. Yeah, that's one of my MDTs. That's why I'm like all excited. Okay, so it's working. Excellent. I'll give you my details afterwards so we can touch base. The answer to that is you should ask people about their family history, but we don't care for this part. So if they've got a family history that worries you on top of the IHC, then they should be referred separately. But they could have nobody in their family history. If the IHC is abnormal, we need to think about germline testing. So I'm glad to hear it's going well. That's good. So the next step, once we've identified these people, is we need to make sure that they're having the correct management. And I don't know what Leanne will be talking about next, but it may be that this is one of the problems that she's aware of as well. It is very widespread. Lynch syndrome expert hubs are being set up across the country. We're setting one up for East Midlands, and this will discuss every person diagnosed with Lynch syndrome at the point of diagnosis. So whether they've got cancer or not, once we know that they're at risk. So we're going to make sure that they're getting referred to the NDRS that will automatically call people every 2 years for colonoscopies, like they do with mammograms. So that will happen for everybody. People can't be lost between the cracks, we hope. And these expert hubs will also discuss testing for H. pylori, which is a gastric risk factor, treatment with aspirin, and referral to gynecologists for women to discuss preventative surgery. I can see somebody frowning. Did you have a question? You looked concerned. No? Oh, okay. Sorry. So these Lynch syndrome expert hubs will make sure that everyone's getting the correct screening and referred onto the correct places. Oh, and if people have got cancer, then we're going to have oncology and surgical representation. So things like immunotherapy will be discussed at the point of cancer diagnosis. Okay. Any questions before I pass on to Leanne, who will be much more interesting, I'm sure. Absolutely. So I don't know your name, sorry. What Anita is saying is a lot of colorectal and endometrial cancer show loss of MLH1 in the tumour. That's because it's, as you said, the stupid cancer cells making a mistake. It's just in the cancer. What we need to work out is whether the mistake is in the cancer that's happened by chance, or whether that person was born with a gene that's not working, that's caused the cancer to occur in this way, which is why you need more testing. Yeah. Yeah. So most people do a H. pylori by breath test, and the GP does it. So we just refer to the GP and ask the GP to arrange it. And if they find it, treat it. It actually lowers the risk of gastric cancer by about 30%. So it's a big thing.
Is it just once? That's what I'm getting.
We just refer for it once. Unless people show symptoms at a later point, then we would just do it once, yes. So I've got into trouble with my oncology colleagues for going into this too much, but yes, immunotherapy can be really helpful, particularly with endometrial cancer. You can have stage 4 endometrial cancer that would have been terminal before and that can live a long time, maybe even be cured on immunotherapy. So at the moment with endometrial cancer, you have to have had chemotherapy before you can have immunotherapy. That hasn't changed yet. I expect it will. These drugs are very much like the PARP inhibitors that we have to start off with 3rd or 4th line treatment before they bring them further and further forward. So at the moment, people do normally have to have had chemotherapy. For endometrial, I think it's slightly different with colorectal.
Yeah, I was just going to say, if you go private, you can have immunotherapy, which is unknown.
No.
But I know that we are looking at more and more going down the immunotherapy route rather than
It is. It's really difficult because obviously until NICE catches up with all the research that's been done, our hands are tied quite a lot. We kind of have to follow their recommendations. But it is progressing. We're getting there. Leanne, do you want to? Very cute picture. So this is Jasper, my little boy as well, who's kind of a bit of the subject of my chat. So as Vicky mentioned, my name's Leanne Barrett. I'm a Lynch syndrome patient. So I just wanted to chat to you guys just about my experience, how it came about to discover that I had Lynch syndrome, and sort of the positives that I've had from the understanding of Lynch syndrome and the care team that I've had as well. So back in spring 2009, my dad developed bowel cancer. He had some symptoms and he'd been to his GP, he'd been trying to get checks and things, but I mean, it was a while ago and things were missed in hindsight, but eventually his tumour perforated his bowel, so he had a lot of implications. And he was in intensive care. It was not a very nice time for anybody. Luckily, he's had a long recovery, but he's cancer-free now and everything's good. So when we were going through that with my dad, though, it was me, my sister and myself at the time, our grandfather as well, my dad's dad, had bowel cancer and passed away from it many years before. So we sort of put two and two together. We were talking to his consultant at the time, who was really interested in us as a family as well. And we sort of said, do you think there is any link? We weren't aware of Lynch syndrome ourselves at the time. And he recommended us to, I think they tested his tumour on sort of the basis of talking about the family history. It wasn't an automatic thing at the time. And then discovered that it is linked to MSH2. Myself and my sister went through a lot of counselling to talk about the effects if we were found to be carriers of Lynch syndrome. And we were linked in with Julian, who's with Vicky at Leicester Royal Infirmary as well. And from the moment that we met that team, I felt, for me, like we were taken under the wing, and sort of there's so much education and positivity around this as well. So I wanted to touch on that within this talk, and just how being that the patient on the ground experiencing this. I know talking about some of the language that's used earlier on with patient-facing people, it's just that understanding and that friendliness and that warmth, and that's one thing that stood out to me with Julian and Vicky particularly, that you feel looked after. And from that point, it turned out that I had got the MSH2 mutation, isn't it? So mutation. I have got the MSH2 mutation. My sister hasn't. So we were grateful for that at the time because my sister had a child, I didn't. So I felt almost the best out of the both of us if one of us were going to get it. So life at the time was different. I was only 22 at the time, so I was quite young, naive, didn't really want to think about having children at the time. So for me, there was a lot of counselling afterwards and just sort of talking through, having annual reviews, where I am in my life, what new developments there have been with treatments or research or any other new tests like H. pylori tests that you mentioned as well. I was picked up from my annual review and check. Luckily, I don't have anything associated with that, but it's just there's developments all the time. It's ongoing. So for me, having that annual review is really great. I do have every 2 years I have a colonoscopy, which is great. So hopefully nobody in this room recognises me from that or any aspects of that. But I'm constantly reviewed and constantly checked. So again, with the endometrial side of things as well, I'm on sort of annual or biannual reviews of that and get tested regularly. So although it's not a great thing to have MSH2, for me, I just feel that the experience in finding out and the experience afterwards has been a great support, and it's enabled me to make informed decisions about my life and how it affects me, having the knowledge and having the understanding and having the support in a positive way as well. So when we found out about it, I spoke to sort of other family members. Some people came forward and got themselves tested just to see if they could make the same informed decisions. Other family members, as a Barrett thing, it's what we tend to do is bury their head in their sands and choose not to act upon it or do anything with that information. But I felt that I needed to let them know, as I'd expect them to let me know as well.
So yeah, I'm part of the screening program, which has definitely benefited me. Another thing that I was able to do with having this knowledge was when I was ready to start thinking about having a family, we were offered IVF with PGD to eliminate that risk to our child as well. So it was not the most romantic conversation with my partner when we were talking about starting a family, but I was always very honest and open from when we sort of got together that if we are looking to go that way, this is sort of the way that I'd like to do it. So yeah, in 2015, I think we approached Julian to kind of say, I'd been seeing him for about 10 years at the time, and he was quite happy that I was ready at that point. But again, just with the knowledge and the information, so we managed to get referred down to Guy's in St Thomas down in London for IVF with PGD, and it enabled me to be able to, go through the IVF process. Obviously, a lot of you are probably aware, so apologies if I'm covering ground that you know, but we came out with 4 embryos, of which were tested for the genetic malfunction. 2 of them did have it, 2 of them didn't. So we tried with Jasper. This was January 2017. We were implanted, and he's just graduated from nursery, so he's 5 years old now. So, but again, it was just knowing for me and seeing how my parents felt after I was told that we got the syndrome. Well, I got the syndrome. My parents felt so guilty. Obviously, they were completely unaware at the time. They didn't know there was any family link or anything like that. Whereas for me, having the information, I've managed that he will never have to go through any screening. One thing for me going through this is that my partner always laughs as well whenever I get a letter for an appointment. He's like, you're such a drain on the NHS. And I'm like, I know I pay my taxes, but just for him, it's like as lovely as everybody makes me feel, having these regular screenings and regular tests all the time, I do feel like there's probably a lot of better time that could be spent, but he'll never have to use that time as well. And it was an option that was given to me because of these guys that he won't be in that position where he needs regular screening or runs the risk of passing it on to his family as well going forward. We did have another embryo. We tried that 2020. It didn't work out, which in hindsight was a good thing because I was tested a few weeks prior to that, and there's actually flags from an endometrial, I can never say that word, so endometrial point of view, which obviously, as Vicky's just ran through, I'm higher risk anyway. So we've been able to do more tests since that, whereas if I had got pregnant, I may not have been able to have those tests, and I might not be in the position that I am now again. So it's a bit of a grey cloud, but there's a silver lining there as well with it. So it was... so now, sorry, along that as well, we are looking to go for preventative treatment. I'm on a waiting list now to have a hysterectomy. But it's a bit doom and gloomy, sorry. But just the overall message of all of this is that I wanted to say that just being armed with the information, everybody here having an understanding about what people like us are going through and our life choices because of it is just a real help. So I've been for screening, I've been for things when... well, I was 22 when we found out, but I was not your usual patient, I think, that people were seeing. There's a lot of times where people were kind of questioning me, like, oh, why are you here? And I'd say about Lynch syndrome, and they weren't aware of it. So I was almost having to explain, and I'm definitely not from a medical background. I work for a clothes firm. I try and sell clothes. Trying to sort of justify why I was there, whereas the fact that you guys are all here in a room today and you're learning about it and you're looking at how you can encourage that amongst each other as well is I'm so grateful for, to be honest, and just having an understanding and empowering patients to make informed decisions for me is only a positive thing. So yeah, there's lots to be done, but I think we're heading in the right direction, and I'm just grateful for everybody and Vicky and the team to be doing what we're doing, really. So thank you. I've rambled on for far too long, so.
Thank you. Okay, so taking us on now, we're going to be speaking with Gemma Gunn. Hey, I'm hoping to see your lovely face. So thank you very much, Gemma. So Gemma is the GMSA Genomic Lead Clinical Nurse Specialist, and her passion is tackling health inequalities, and she's speaking to us today about United Against Prostate Cancer and the project and patient journey. You're already geared up, aren't you? Do you need that one?
Let's try to Right, thank you. I'm not sure how I quite followed that. Thanks, Leanne and Vicky, that was amazing. Okay. So yes, thank you for today. So I'm going to talk to you about the United Against Prostate Cancer project. I know I've spoken to a few people already about it today, and we've got some information at the back. If you do want further information, you can come and have a chat to us. So as a project, we're one of the East GMSA's transformational projects. It's a local one, so it's not one that's run over nationally. It's something that we're very much running over the whole of the East GMSA, though, so across the East Midlands and East of England. And we're looking at ways to come together collaboratively to tackle health inequalities in relation to prostate cancer. And so in the terms of collaboratively, it's absolutely both within the clinical setting and the community setting. So we're working with our clinical and scientific colleagues to establish genetic testing pathways to pilot that. And we're also working with our stakeholders and community champions to look at outreach work to address the health inequalities. And the reason we're doing this really is to look at improve the care that men and their families get surrounding prostate cancer, and identifying areas of high-risk groups, individuals with a family risk, individuals with African heritage risk in terms of prostate cancer, and also in terms of access to genetic testing. So why prostate cancer? That's quite big on there. Well, actually, it's the most common male cancer in the UK. 27% of those cancers are male cancers, which is the equivalent of 52,000 a year. This is obviously projected to increase. And like with most cancers, the earlier we pick it up, the better the survival. We think of what 1 in 8 will develop prostate cancer in the UK, but actually that's 1 in 4 if you have an African heritage, so 25%. So that's one of the reasons that we were looking at prostate cancer. What we needed to initially do then was, obviously we're talking about health inequalities, but we needed to find out what they were, who was at risk. So we identified that anybody with a family history, be it first degree relatives, so father, brother, gives you a 2 to 3% chance of increasing your risk of prostate cancer. And again, even second degree relatives, either having had or have prostate cancer, increases your risk. This increases further if these affected relatives in your family are under the age of 60 when they were diagnosed. And again, if you've got more than one family member with prostate cancer, your risk also increases. If you've also got a history of breast cancer in your family, as well as prostate cancer, the risk increases. So again, we know there is a family history link, and we know that by identifying that within your family, you can recognise whether you're at an increased risk of prostate cancer. We also know that if you do have BRCA mutation, so it's BRCA2 mutation, and as Vicky's just mentioned, Lynch syndrome, you are actually at an increased risk of getting prostate cancer. So it's important that we do identify if patients are carrying these mutations, because again, they can be more aware from their own health point of view, family history, and again, accessing more testing. And as we just touched on, we also know that in terms of ethnicity, there's inequalities. So 1 in 4 black men will develop prostate cancer, which is twice as likely than a white man. This tumour is often more aggressive, and you're twice as likely to die from prostate cancer if you're black than if you're white. So we've identified that there's a family history risk, there's an ethnicity risk, and if we do identify changes in terms of BRCA mutations or Lynch syndrome, you are also at risk. So again, what we wanted to do was a double-pronged approach here. We wanted to look at a clinical pathway to see if we could identify ways of genetic testing for these members, to see whether or not we could identify patients at risk of known mutations. And we also wanted to do a community outreach piece to see if we could raise awareness within the communities to actually encourage people to engage, identify their own symptoms, be aware that there is access and support for you if you do identify problems, and also to enter into conversations about genetic testing, because not everybody is a fan of it. We're all here today learning about it, but actually there's a lot of community engagement to actually help people understand what it is that we're trying to achieve. There's still a lot of distrust there. So our clinical pathway, I guess the obvious one was, let's just test more people. Let's see if we can, these patients who are at risk, let's get them in, let's test them. That would give us the answer in terms of BRCA, whether or not they're a carrier. Slight problem there. So most of the time, people know the referral to clinical genetics as germline testing. That's the blood test most people come for. If you have prostate cancer, you must have a Manchester score of over 15 in order to qualify for germline testing. And as you can see here, it's going to take quite a few family members for you to get a score of 15 to be eligible for germline testing through clinical genetics. This is not comparable necessarily with other tumours. So again, you know, just there in terms of breast cancer accessibility, just a list of people who are eligible. So again, we recognise there's a bit of inequalities there in terms of tumour site, but we needed to think of another way to do this rather than just through germline. And so we can't do germline, so we had to then look towards another option, which is the somatic option. Again, somatic testing, as you know, Vicky's just mentioned in terms of Lynch, is actually testing the tumour itself, so testing to see whether or not it's something that could have been inherited during a lifetime, as well as potentially being inherited. And so by testing the prostate cancer itself, we're able to test whether or not somebody has a mutation that they have either acquired during their lifetime or has potentially been inherited. And as with Lynch, in order to establish that, if we do find a mutation somatically, we do then refer on to clinical genetics, and patients are then eligible for germline testing. So this is a way where potentially they weren't initially eligible, but because we found it somatically, they are now eligible without thinking about the family history aspect. And so before we set the pathway up, we did need to obviously think through 3 things. You know, people can't unknow the results of these tests. So again, thinking about making sure that people are fully informed about the tests that they were having and making sure the implications of that was fully disclosed. You know, it's a patient choice. We have to understand that not everybody wants that, and again, we have to fully respect that. If they want to talk to us about it, absolutely fine, but even after that conversation, if they don't want to, they don't want to. For us, that was an option. Now, we aren't doing this as standard of care testing. This is absolutely a pilot, and so for us, this forms part of that. Again, we had to understand if there was anything that could be done after we've done this testing, so what were the implications of this testing? We were hoping at one point that we'd be able to offer treatment based upon the results, but unfortunately NICE at the minute haven't approved that treatment. So the majority of the work that we've been doing is very much about family history and enabling testing for families who want that testing and they aren't able to access it through the traditional route. Again, the results of that can sometimes explain a strong family history, sometimes not. But again, you know, as Leanne just mentioned, not everybody actually wants to know the results, not everybody wants it. And so it can affect family dynamics in some situations if some family members want it and some don't. So again, it's just things to think about before we kind of moved forwards with our testing. So then we went ahead and developed our pathway, and this was just a few arms that it took for us to actually get this pathway up and running. Won't touch on all of it because you really want to go home today. But a few things that really I do want to give a heads up for. At the bottom here, we're talking about our actual testing pathway from the sample side of things. This has been a really important collaboration between ourselves, by our colleagues in the laboratory at UHL, and also our colleagues in the laboratory at Cambridge at the GLH. The team at UHL process and section and sample and send to the GLH all the samples for our project. So they request them from wherever the patients had them in the UK. They have told me they can do them outside of the UK in some situations, but we've not been in that situation, so we've not had to test that. But they will request any samples for any of the patients in the East GMSA and process them here at UHL for us. They send them off to Cambridge, and the team there have had to devise the test in order to test the samples. So as part of this project, they've had to develop the test in the laboratory in order to test our samples for us, and we've had to get that validated. So again, when we talk about collaborative working, it really has been, you know, each part on this stage have had to really work towards getting the outcome for us. That's been validated, and then they send the report back to my colleagues in Leicester, who then upload it for us here, who then also return that back to the referring trusts. So again, each step is multi-layered, and it really has taken a team effort and a big piece of work from everybody to actually just achieve a very small sort of what seems like a quick pathway, but actually has taken quite a bit of work. And so our results so far, each test, and again something we haven't particularly touched on, is actually these aren't quick. It's not quick from the point that potentially you test that patient or get that consent to the results coming back. If we're retrieving samples from elsewhere, we're probably looking at 2 to 3 months for these results to come back. So that's why it's taken so long for us to even just get to 7, now 8 patient results, because actually by the time we've set the pathway up and then we start to get the consent from the patients, it can still take a bit of time. So we are looking at about a month and a half from the samples arriving in Cambridge to getting those results back. We've had 4 negative, which again is good for the patients. We have found limitations on our testing ability, and so when we've got small tumours, we've not actually been able to extract enough DNA to get an answer. We actually, hot off the press as of yesterday, have found 2 BRCA2 mutations, which neither of these patients would have been eligible for testing through the traditional routes. So we've actually been able to find these mutations, which they wouldn't have known about in any other way. We do, however, still need to establish whether or not these are inherited and inheritable, so they do need to have germline testing if they wish. Okay, so we have already seen one of these patients, and this patient has now undergone germline testing, and we're waiting for the results. Like I said, the other one was hot off the press yesterday afternoon, so we're not quite there yet, but by the end of the week he'll know. And then obviously we will also be offering germline testing then to see whether or not we have picked up a germline mutation. So, onto the community outreach bit. It gets a bit more cheerful now. Again, big piece of work. Community engagement is very much about, we had to identify our high-risk groups. We had to think sort of outside the box as a way of getting into these communities as part of the project to actually raise awareness. We've identified stakeholders because, you know, nobody wants something done to them. We want to do it with ourselves, in collaboration, within our communities. And so we've had identified stakeholders who are very much experts in this field. And we've also looked to recruit peer-patient champions, so people on the ground within the communities who can actually help champion the work that we're doing, so it's happening within the communities rather than us telling people. We've had to work a lot on identifying events. We're doing our own events. We've spent a lot of time doing our advertising materials, as you can see. And again, when I'm linking in with our PPV panel. And each step, as with the other one, has led to a few extra jobs, and this has taken quite a few months. We've had lots of meetings, and again it's shown when you're working for the East GMSA, which has been great. We've been hosted by UHL, but we're again working outside the hospitals. We're working across regions. Again, we're working with community champions, contracts, legal. There've been quite a lot of hurdles that we've kind of had to jump through just to make sure that everything is covered when we're working across multiple organisations, multiple boundaries, but we got there, and it's been great since we did. Like I said, just a shout out to our amazing stakeholders. We have Prostate UK, which is a fantastic local prostate charity, really, really dedicated, impressive, do a lot of work, including funding nurses, funding equipment, absolutely brilliant. Be Me Against Cancer is Nottingham-based, and they're very much involved in protecting and supporting the Black and minority ethnic communities, and they have been incredibly generous and supportive in making sure that the work that we do is appropriate for the Black community, and support us in terms of training for our peer-patient champions to make sure that we are communicating in the correct way and making sure that that information is accurate. And the Centre for Ethnic Health is based here in Leicester, and again, very vision is to reduce ethnic health inequalities, very much involved in many, many arms across many different specialties in many health conditions. And so we've been out and about doing a few things. So here's all our information. Collaborative working really does pay off too. You even get videos with Sir Lenny Henry to use. So I won't click on it now because you want to go home. But the Centre for Ethnic Health, in collaboration with a lady called Pamela Campbell-Morris, did a big piece of work within the African heritage community with prostate cancer, looking at appropriate ways to engage with the community. And they came up with this model, which was Play Domino, Talk Prostate. And as part of that work, the late Pamela Campbell-Morris got a lot of celebrities involved, and so again these videos have been generously shared with us as part of our project to help us raise awareness and use that material. So again, collaborative working really does pay off, and we're also able to support them with the work that we're doing and support them in the community. So these videos are freely accessible on the websites. It's worth a watch. And again, we've got toolkits as well that are available, as well as the work that we've been doing. And like I said, the Play Domino Talk Prostate has been very successful here. And again, it just shows how when you use the right tools, you can engage with the communities, and the communities want to come and engage with you. So this was an event we went to a few months ago now. Again, if anybody's not been there, it's amazing. The noise, the atmosphere, it's great, and it's just a way of bringing the community together, all ages, gender, it doesn't matter. Come together, game of dominoes, decent food, the music's on, but you have guest speakers, and it's such a wonderful, warm environment, but it's also educational. We've taken this model forward as well with the permission of the family. We did obviously link in very closely with the late Pamela Campbell-Morris's family, and with their support, they're actually agreeing to us taking this across the region as well. So we're using this as a foundation for some of the work we're doing. We have an event on the 5th of December, which has actually got interest from the national NHS England, and we've got them coming with some comms to do that. And they're also looking at the big picture, looking at very much what we're doing, and working with the laboratory, filming in the labs, following the whole patient pathway. So again, really, really good to see. But, I'll have to go back one. But it's not just dominoes. We've been off in Norwich in the market. Maria, who's here, again, with one of our peer patient champions, Dee, meeting the Mayor of Cambridge. In the middle, that lovely group photo there is us with the Lord Mayor of Leicester. Here, again, we've just been out and about. We've been to Leicester Football Club. So we really have been getting out and about just to try and engage with communities as we've gone along, because, again, going to these events is the way to move forwards. And again, we identified, there are areas which predominantly are white. So again, trying to find ways of getting into these communities. So here we are in Market. It was just in the main city centre. 1.6% of the population of Norwich identify as African heritage. But by targeting somewhere that was much more about their heritage, we actually had a much higher pickup than that in terms of people that came to speak to us. And I think that's pretty good going, because when you go out for your shopping, you don't really want to talk about prostate cancer. So I think I'm still quite impressed that we got that many people come and talk to us. But I think it must have been Lenny playing in the background, because we had him projected behind us that got the attention. But really good. And actually what was really positive is, again, just opening that conversation, talking about genetics, talking about prostate cancer, and so many people were like, well, we didn't think we needed to think about it. Do we need to know about it? So again, just really informative. And we'd often get people taking leaflets for the husband going, I'll show him that later. So again, that conversation will continue. So just a few things. So, we're not finished. We've got another 5-6 months left, and we're already booking our next slots. Maria and I are dividing and conquering on Thursday, because we're between us. One's in Ipswich, the other one's in Milton Keynes. Again, just looking outside the box. Again, we're looking at linking in with unions. I'm off to, this Cancer Risk Talk, which is a Macmillan talk. I met up with a play called 1 in 4 in Birmingham a couple of weeks ago, which again, a lady in London had put together to discuss prostate cancer within the Black community. She's devised a play, and she's looking for support to put it on in different regions. So again, I went over to see it a few weeks ago, and we're going to see if we can link in to support that again going across the region, because this is about not just us doing things, this is about us supporting what's already out there. It's about uniting everybody, not everybody doing it in those silos, because together you're stronger. So again, bringing everybody together who is already really passionate and working in this area, and through the connections we're making, bit by bit, we're starting to see the work and how we can support each other. And so, before I finish, I'd like to hand you over to Eddie, who's one of our patient and public voice panel, who's agreed to come and talk to you today, again, just about our project on prostate cancer.
Yeah, that grinning tan person at the top is me when I was playing lots more golf than we're playing at the moment, but that's the weather, nothing to do with prostate cancer. As Gemma says, I'm vice chair of the public patient voice for East Genomics. I'm actually a molecular virologist by training, so I'm a scientist and I've worked in infectious disease, respiratory disease, oncology, particularly immuno-oncology, and more recently neurosciences. So I've got a very good scientific understanding of what I'm going through as an individual from my prostate cancer diagnosis. This diagnosis happened just after I joined the panel, actually. And it was a result of going for routine health check. And I said to my GP, you know, I've turned 60, how about doing a PSA test? So then I had to be counselled about how, if it's round about 10, it can't mean anything, you know, so just be aware of the limitations of the test. Of course, the result came back and it was 600 nanograms per mil, or what's that in micrograms per litre, 600 anyway. I said, that can't be right. So they redid the test 2 weeks later and it was up at 700 odd nanograms per mil. So the diagnosis pointed pretty clearly to advanced metastatic prostate cancer. So then I went through a CT, went through nuclear magnetic resonance bone imaging, had some tissue biopsies taken, which are going to Leicester as we speak, I think. And again, I've had a DEXA recently, and bones are fine at the moment. So I've been through all the tests that then combined established that indeed the cancer had spread from my prostates from very small nodes to lymph nodes and to bones in a number of places in my body. So it's quite widespread. So, you know, the message, one message is, you know, why isn't screening offered for prostate cancer? Because I was symptom-free, and it was only by, I think by luck, that I went to a doctor and said, as part of my health check, how about PSA? I wouldn't normally have asked for it. I don't think many people would normally ask for it if they didn't know about prostate cancer, a little bit of scientific background. So, you know, I think one of the things I'm going to try and do is lobby for a national screening program like bowel cancer, like cervical, like breast, because prostate cancer is so not devious, but it's there and people don't know about it. So symptom-free, shocking, this test. So what does the future hold for me? Well, as I said to Jem and others, my wife had breast cancer, so she's been through chemo and radiotherapy. So I know that's probably coming for me, and it holds no fear. If my wife can get through it, then I certainly can. But she won't be offering any sympathy. That's the worst thing. Absolutely no tea in bed, nothing. Get up, do the gardening. The other thing that's quite exciting is, because I'm a scientist, I've been doing a lot of reading around this, and actually I met a prostate cancer surgeon last week at just an hour conference I was at. And he said to me, what's your diagnosis? And I said, advanced stage 4. I said, oh, never mind. I'll see you in 10 years' time. So that's really positive, because next week there's an hour conference I'm going to, and it's about the transformation of prostate cancer care. Over the last 10 years, as Gemma was showing, the survival for stage 4 cancer has gone from a tiny percentage to almost 50% survival at 5 years. And I'm sure it's going to keep going up. And just on the radio this morning, I don't know if any of you heard it, but the team at Institute of Cancer Research believe they can treat all advanced cancers, metastatic cancers, with some of the treatments they're developing, which is kind of what we're talking about earlier around Lynch. It's not just about the tumour, but all the stuff that builds around the tumour, you know, the extracellular matrix and feeder cells, they can target that. So I think the prognosis for cancers, and particularly for prostate cancer, is beginning to improve. And, you know, hopefully over the next 5 to 10 years, I'll be a key beneficiary of that. So my last message is, don't just live with cancer, but live with hope. So thank you for your attention.
Thank you. That's brilliant. So Lisa is the epilepsy nurse specialist from Nottinghamshire Healthcare Trust. And I think if everybody takes time to look through the biographies, you can see that this is a real passion for Lisa, and she's an expert in the area. So we're very fortunate to have her. So thank you.
Thank you. Thank you. Hiya. I'm really going to speak from a nursing perspective in the epilepsy world, really. And I'm probably speaking to lots of people who may not know much about epilepsy, because that generally is the case out there. I mean, I don't want to put hands up, we're not in school or anything, but I'm sure, you know, I'm hopefully going to learn a little bit about it. I'm going to talk a little bit about the diagnosis of epilepsy initially. But my background, just to speak about myself really, is I'm a learning disability nurse, trained nurse, and I've been nursing now for 34 years. And this is really kind of, epilepsy has become my passion over the last 12 to 15 years, but mainly because of the drivers that have gone forward for how it's changed people's lives in the learning disability world. And just being allowed to get maybe some clarification on a diagnosis through genetics or the changes in the genomic world has been beyond anything that I could have ever hoped for when I started nurse training in the 80s. In the 80s, there were the basic tests, and people in the learning disability world, you know, we've all heard of people with Down syndrome, maybe possibly Rett syndrome or Fragile X. They were really all that people ever really knew about learning disability, and that is all I was taught as well. And it was a huge learning curve for me throughout the years, and all the years that I've been in different posts within my trust. I've always remained within the same trust. Because of the opportunities that have come my way through learning disability nursing, until my world changed in 2010. Are we on? Where are we? Oh, here we go. So we go back a little bit. In the world of epilepsy, in about 2010, when I actually started my nurse prescribing role, which then I met the epilepsy team in the neurology service in the acute hospital in Nottingham, because I've always worked for the Little Learning Disability Trust, Nottinghamshire Healthcare. And I thought I was a very experienced learning disability nurse until I went into the world of epilepsy. And I did not know anything about epilepsy, when actually epilepsy was kind of a condition that is so common in people with learning disabilities that I was kind of shamed into not knowing what I should have known in all of those years of nursing. And I think part and parcel of that is not just because of learning disability being a label for some people, but also that epilepsy comes with its negative impact that people feel it has on their lives, and especially that stigma still associated with the condition. And unfortunately, even though it is a very common neurological condition, that tends to be the biggest problem we have with supporting patients out in the community of what epilepsy, the implications of epilepsy on lives that it can have. This ancient photo, I don't know if anybody recognises the Transfiguration of Christ by Raphael in the 1400s there. I didn't. But can anybody spot in that picture the young boy who's having a seizure by any chance? Yeah? You can see him in the blue little throw around there, and they're all pointing at him because it was a kind of a spirit, kind of a possession, that some people still feel that epilepsy, you know, can be derived from something like that, which is obviously not true. But this is the world that we're in, and unfortunately that's why we don't talk a lot about people who experience seizures on a daily basis. Some people experience hundreds of seizures quite frequently, and the impact that it can have on your lives, and especially for those people who I advocate for in the learning disability world. Sometimes they don't have a voice, and it's us to be able to provide that for them as advocates in this nursing group. Okay. So what is epilepsy? I'm just going to give you a bit of a whirlwind tour of what epilepsy is. So epilepsy is a disease of the brain associated by reoccurring seizures. You know, to have one event, you don't always get the diagnosis of epilepsy. It's about having reoccurring seizures through lifetime. What are seizures? Well, the transient signs or symptoms to abnormal, excessive, synchronous neuronal activity in the brain. And just to simplify it a little bit, wherever in the brain that's happening, that's why a seizure looks the way it does. And that's why seizures can be perceived as very different in different people. And there are many, many different types of seizures. So this is another reason why it's hugely misunderstood. It's a very common brain disorder. And I'd say it's probably more than that now, but I'll say what the literature says. And it's around 600,000 people in the UK at the moment have the condition diagnosed. Sorry, I've got a croaky voice. That equates to about 1 in every 100 people in the UK. So it's more common than people think for the people who don't understand the condition. And it can affect anybody at any age. There are certain childhood epilepsy syndromes, but then sometimes some types of epilepsy do not, you can obviously develop epilepsy later in life too. Okay, so just a little bit about epilepsy in the intellectual disability world, the world that I work in. It is hugely more common in the general population. What we tend to see is, as we've got there, the prevalence increases with the severity of the disability. And, you know, I would say somebody with a diagnosis of a profound learning disability would be 50 to 70 times more likely to have a form of epilepsy. But the problem is that it's relatively severe and it's sometimes not diagnosed or not known to be a type of seizure type, because we can tend to see more rare types of seizures. So it's a very misunderstood condition, especially in this patient group. But of course, as we say there, it may be obviously just as responsive to treatment with specialist intervention. Doesn't mean we give up. There are lots of new medical treatments, which is obviously why I'm here today, because we've kind of got those huge drivers out there now about new treatments, which is now being obviously coming out now because of the changes in the genomic world, and especially huge changes in the learning disability world. So just quickly, my kind of practice is driven by the International League Against Epilepsy. And this is the kind of guidance they give us in trying to get a diagnosis correct, because the diagnosis of people with epilepsy can be very lengthy. It can take many, many, many years to get a diagnosis correct if we don't have good history, if we can't access the investigations that we would like, and especially things like genomic testing that have not been available for many years for people previously. That's available now. Diagnoses now, we are finding that we can do this sooner than later, but still for many people we still can't access these investigations. So we try and find a seizure type for somebody. Fundamentally, it's about finding the actual etiology of why somebody has the condition in the first place. And there are many reasons why people can develop epilepsy in life. We've got obviously genetic being one of them up there. This gives us sometimes what we say a classification of epilepsy, and by doing that kind of can plan the way I can look at somebody's care and treatment choice, because certain types of epilepsy are obviously better suited by certain treatments, and especially there are certain treatments we should avoid in certain types of epilepsy because we can make seizures worse. We're trying to get to this epilepsy syndrome kind of diagnosis. If we get to this stage with all the correct information we can find, then hopefully we're on the right path for treatment. Okay, so just some I won't go through it all, but some causes of epilepsy just for interest really. Obviously we're here today talking lots about the genomic world, and genetics is why we're here. And in the epilepsy world, my consultant neurologist who I work with very closely is very passionate about this side, and we work very closely with our genomics team in Nottingham. And we were part of what we heard earlier this morning about the 100,000 genome study, and we recruited over 200 people to that study, and we'll get onto that later, but it fundamentally has changed lots of people's lives because of that, just that opportunity of accessing that study. As you can see, genetic just isn't the only cause of epilepsy. Most people think it is, but it's not. You know, there can be structural causes, and we have a few obviously scans on the side there with, I don't know whether anybody understands scans there, but I can clearly see some causes there of epilepsy and some malformations of the brain. And there are different, as you can see, you may see obviously genetics. We've got the Down syndrome. Dravet syndrome is a syndrome I'm going to specifically talk about because we've got some targeted treatment specifically for that type of epilepsy. Tuberous sclerosis as well is highly prevalent in the learning disability world, and I'm going to talk a little bit more about that as well, because of the treatments that have been found which obviously target because of the genetic results that we have now, so we can target specific treatment for that condition. And there are other causes of epilepsy as well. So thinking specifically about genetic disorders in the epilepsy world, there is an association with learning disabilities, but having a learning disability isn't the cause of an epilepsy, of course not. But what we found through history and through, you know, and I can say through personal experience, is that genetic testing may not have been available or even offered to people with a learning disability. You know, there's nice guidance out there that we should be offering genetic tests, but personal experiences, you know, I see new patients all the time for diagnosis, and quite frequently lots of people have not even had any kind of genetic screening. Some obviously do, and that's great, because obviously the process becomes, a lot easier. But it is a case that we drive now to make sure that everybody has a full genetic screen. What we tend to find is those, especially NICE guidance also tell us if we haven't got a clear cause of somebody's epilepsy, and especially if we have somebody with a learning disability and other additional features, as in some kind of things like dysmorphic features or, experiencing seizures, then we should be clearly trying to find a genetic cause for that. In the learning disability world, however, it can be really difficult to get a diagnosis correct, mainly because of the complications that come with that. Sometimes we can't access investigations. It's not easy to get somebody into an MRI scanner without maybe a general anaesthetic, or for somebody to tolerate an EEG. It's not always that easy. And there are many, many different types of seizure types out there that there's lots of still misunderstanding about. Most people recognise the tonic-clonic seizure or the blank spell, or maybe some subtle jerk-like episodes, but there's many, many, many more types as well, which is, we're still learning about now. And, genetic causes that we see quite frequently in the learning disability world are Rett syndrome. I don't know if anybody's heard of that syndrome, where we know there's a high prevalence of seizures in people with Rett's. Also Angelman's, Fragile X, and trisomy 21, which is otherwise known as Down syndrome. And we know people with Down syndrome have a high prevalence of developing epilepsy late on in life, what we call late onset generalized epilepsy. And that tends to be associated with their prevalence of developing dementia as well. So, just knowing this already, it's trying to understand these conditions more, and obviously looking at trying to get those genetic diagnoses correct, because then we can target the right treatment. Just a little bit about Rett syndrome, because I support lots of people with this condition. As you can see, there's 1 in every 10,000 to 1 in every 23,000 female births with people with Rett syndrome. Initially, it's not spotted because there is initially normal development, and there tends to be a regression from the age of 12 to 18 months, and that's when things are noticed about loss of speech, and what you tend to find a typical characteristic such as wringing of the hands and hyperventilation as well, what we tend to see. And in this group, there's a high prevalence of epilepsy of 70 to 80% of the diagnosis, and that can be a mixture of different types of seizures, whether that be focal type or generalized types of seizures as well. Tuberous sclerosis is a huge group that I tend to support specifically. I don't know if anybody's heard of the tuberous sclerosis guidelines that we have in the UK. There's lots of surveillance around this, because people who have TS should be having annual surveillance, including, because we know it's a rare genetic multisystem disorder that can not just affect the brain, so obviously that's why somebody may develop seizures, but also that it can affect the kidneys, the lungs, the skin, and people do need surveillance for that, because people can experience change throughout their lives. There's different, what we call tubers in the brain, which MRIs that we can pick up from, so that where diagnosis can come from there. But again, this is a genetic cause, and there's lots of genetic counselling that families would need if this is picked up. And just one personal patient story that I've been allowed to tell today was a gentleman who came to my clinic only a matter of weeks ago, and he was in his 70s and hadn't had a diagnosis all his life, but had experiencing seizures. And it was quite, it was one of those cases that was shocking, quite, really, that it hadn't picked up that he had got a diagnosis of TS, because he'd had a scan, but there weren't significant changes on his scan, but he had the other features as well. But the tale with this story was that his children had also got some form of the condition as well, and it enabled him then to be more informed, to be able to share that. But obviously he didn't get this diagnosis himself until he was quite, in the older age bracket with that. So I don't think it would have changed anything, but it would have given him obviously more information throughout life and how to support his family. Just when I went into a little bit on the slide about TS, about how it can affect people differently, and especially in women, we should be obviously more aware that in women they can have a condition called LAM, which affects the lungs, so we need surveillance of that as well, where lots of people haven't previously had that. And there's some chromosomal, obviously, the screening to have specifically for TS. That's just where if we have a typical MRI scan there with some tubers in the brain in the brightened areas there, and how it can affect the skin and other parts of the body as well. Like I say, with a target treatment, especially for something like TS, and I've attended many meetings with the Tubular Sclerosis Society. There are now specific treatments for people with TS, and they've come about in the last few years. Everolimus and sirolimus can now be treated to stop the further growth of the tubers, but also can be helpful for the changes to the skin, which can be really quite detrimental to people, in their daily lives. And then Dravet syndrome is another syndrome that we see in the epilepsy world. It is intractable for epilepsy from early life. It tends to be from very early, following birth. The seizures tend to appear following fever and vaccination. And it's all to do with the change in the sodium channels and the loss of function in the sodium channels in the brain. So by knowing this diagnosis, we know which drugs to avoid, because lots of the medications in the epilepsy world are sodium channel drugs, so we need to avoid them in this patient group because we can make seizures worse. So just knowing that diagnosis can guide us on treatment choice with that. And you may see some medications there with the cannabidiol. There's been lots of information of that in the press. And again, if we have people with this diagnosis, so to get this diagnosis correct for somebody in the first place allows us to be able to prescribe cannabidiol, because there are certain diagnoses that people have to have for me to be able to prescribe this, or for the neurologist to prescribe this. I am a nurse prescriber, but there are some medications that I still can't prescribe, and cannabidiol is one of those. But again, the diagnosis has to be quite accurate as to allowing us to be able to allow people to have these treatments. So that's Dravet syndrome. And then the 100,000 Genome Project, which we heard a lot about this morning. And I really do feel, and I have been around an awful long time, and especially in the learning disability world, that this project changed a lot for people especially in the learning disability community. It gave us access to these new these new diagnoses that families never knew anything about. We did not know the answers to why their child had a learning disability. And this project, and these are just two examples, and again, one of the families were going to join me today, but unfortunately they just couldn't, just through poor health. But these are the two conditions that were picked up through the 100,000 Genome Project. And just the family at the top, where their daughter, we found that they had the PCDH19. It came with that diagnosis through this test, this genome sequencing test. They had lots of stigma and lots of blame. They always blame themselves for their daughter's condition because they never truly understood why their daughter had this. And I think we underestimate the impact on families that can have without having somebody having a diagnosis. They blamed immunizations, different aspects throughout her childhood. They could never find a reason why she had this. And to get this has just changed their lives, and just it doesn't change the outlook and what's happening, but it allows them to have support from certain groups, from other families in this. I mean, it is a very rare learning disability condition, this, and there's not many in the UK, but it has allowed them to make contact with other families that understand the condition more. So just being more informed has just been helpful with the diagnosis. And then the CASC gene variant is another one of the ladies who I support. Again, I spoke with the family again last week about this. And I think for them, it was more about having that acknowledgement of the problems that are associated with this genetic condition. It just explains why things happen, what's happened throughout their daughter's life, really. So it's just been that awakening of that understanding of the condition, and just knowing the genetic cause of that for their daughter. It brought with that condition, really. So just some take-home messages really from the epilepsy world. So the consultant neurologist I work with, I sat with him the other day to say, well, what do you want me to say as part of the service, really? And I mean, his main take-home message was, we feel we're really just starting in the genetic world, really. Even though we know a lot, we don't know, we're getting new diagnoses all the time, obviously changing the way we practice and what treatments we can offer. So we do have a lot to learn. But I think for me, it's offering us the possibility of personalised medicines and targeting people, you know, in a quicker way, I suppose, to try and get a more, because it can take many years to get any kind of seizure freedom, or to try and get that balance between reduced seizures and quality of life. Because for people in the learning disability world, it isn't always about getting people seizure free. I can keep pushing treatments all the time, but for me it's about how people live and how they live well. That's what's most important. And always remembering, if somebody does come to us who maybe haven't gone through any genetic screening, it's the first thing we should be considering doing. It's so important to do that. And I do feel like, obviously, I work within a service that is, you know, we're really passionate about trying to make sure that we at least get the diagnosis right, because in epilepsy, diagnosis unfortunately has a high misdiagnosis rate. And that tends to be because we haven't got access sometimes to investigations or the information we need, or clinical history. But it can be a very, very, very difficult condition to diagnose correctly. And that's it from a nursing perspective, so I hope that's been helpful. The only thing I want to finish on is a little project that we did as part of Nottinghamshire Healthcare, that we were given some money some years ago from NICE about developing some resources specifically for people with learning disabilities. And we worked with a patient group, a focus group, about access to investigations, because sometimes, you know, some people haven't had a scan or haven't had an EEG. So these are all little short videos to hopefully help the population of people with disabilities to maybe understand why they're accessing tests, or for their families to go through what it's like experiencing going into an MRI scanner. But mainly the one at the bottom, Living Well with Epilepsy, is actually for people themselves who have a learning disability and have epilepsy, and how that they proudly live their lives well. You can access those on our website at the top there if you ever wanted to watch them. But they were great, so they're lovely short films. And that's me. Thank you. Okay.
Mic you up. We'll stick some mics on some of you, and then if you share. Yeah. Okay, so I'll leave you to it.
Okay.
Would you like to be mic'd up? You're a special lapel mic.
Okay. Fine, yep.
This means you have to speak.
Does it have to speak?
The effort he's going to. No, joking.
Am I going up? Was that a question? No, I was going to say, can you join us for the Q&A? That wasn't the question.
It was a rhetorical question.
Oh,
So we've got a couple. So those two sat down definitely. Are you doing roving with me? I don't mind covering the room. It's not that bad. Yeah. Well, so if they're not, I think one of the roving mics should be on that group. 'Cause it's quite a lot of people, isn't it? So yeah. So if you can, I'll just see who wants one. The rest of you will have to share one of the...
no, that's fine if you're off that.
Yeah, and then I guess you can just pass that down to...
Okay, I think we're... Am I on? Yep. I think we're all back in the room now. So thank you very much to our chairs, Naomi and Janet, for leading the Nursing and Midwifery sessions. And thank you very much for all of our speakers. So we've got, I think, all the nursing speakers and most of the midwifery speakers here. So we thought we'd do it as a joint question and answer session because it's getting near to the end of the day. But then also afterwards, we're going to send out the customary evaluation form and sort of slide set. But you could sort of reply to us if you've got any questions for the speakers. And I know Naz has had to go. So over to you. Anybody want to ask the first question? I don't want to say anybody's name. I'll just look at somebody.
Nobody asked anything about epilepsy. Oh, thank you.
Well, I think perhaps.
I don't know where to start with this, sorry. In the middle, the beginning. Hi, I'm Debbie. I'm a lecturer in midwifery. And my mind's a bit blown by all of this today. And I don't know where to start with it. Where can I put this into my teaching? Where would you begin? Because I can't obviously chuck it in everywhere. But
so what university are you at?
Hertfordshire.
Hertfordshire. So I think North West Thames Genetics Centre will be best placed to support you.
That's a bit of a cop-out, Vicky. No, that is true.
And I can put you in touch with some lovely genetic counsellors there. But in terms of actually coming in and giving teaching on your course, I'm sure they'd be very happy to do that. So I would give you their contact details, but I don't know if...
I was going to say, I'm doing a course at the minute and there are lectures on that.
So just to add to that, I think I mentioned earlier that there are 3 universities who have embedded genomics within their curriculum. There's Helen White, who works in the University of Salford. There is also University of Surrey and New Books University. The name escapes me, but I've got names back at base, so I can send you their contacts and you can have a dialogue with them to find out the best positions to start from. But they were like you know, where do you begin? What do I do? I also connected them with Ed Miller from JEP, so you know these universities as well. So that'll be a good place to start.
Yeah, that's a really good question. And I mentioned during my presentation we did some scoping work last year to find out the position of genomics across nursing, midwifery, health visiting, and included universities. And the universities, it was very variable because we had, I know one university on their mental health branch were doing quite a lot on pharmacogenomics. Others were doing very much focus on the biological aspects. And then I know a couple of universities were using Lynch syndrome as a sort of case study. So, quite good. So, any other questions? I sound really menacing here at the front. I feel really menacing. You know, it's late in the day.
Thanks so much. I'm Colette Grace. I'm one of the genomic leads in NHS England. So I'm just going to throw the cat among the pigeons because why not? I like doing it. So one of my questions is, we've talked today about registrants, all nursing, all midwifery, but what about the MSWs? What about the healthcare assistants? What about primary care staff who aren't necessarily qualified? Because we all know that most patients will talk to the non-registrant staff perhaps a bit more freely than they might somebody who's qualified, because they may perceive they have more time. So I just wonder, are we missing a trick? Is it something that we need to think a bit more about?
Just kind of a general query, really.
I'll make a comment and then I'll pass over to perhaps Ed or Donna to make a comment. And I totally agree with you, but Colette, but I would say one of the things about midwifery support workers, healthcare assistants, they all work under they should be working under the supervision of a registered healthcare professional. They shouldn't be autonomous, independent practitioners. So probably I think we perhaps need to get it right for our registrants first to cascade down. I mean, in the ideal world, we'd sort of go to everybody all at once, but I think we're perhaps better to focus on doing a few things well than trying to do everything in a mediocre fashion. You know? Ed or Naomi or Donna, would you like to add?
Always when I've had discussions, round tables with various disciplines regarding genomics, I always mention the maternity support workers. For one good reason, there's a lot of them that actually get involved in screening already. They actually are involved in taking the newborn blood spot with the NHS newborn screening programme and work hand in glove with the midwives. There are maternity support workers who actually work in fetal medicine as well. So, as you were saying, Annette, I think we have to do this phased and targeted approach. And at the moment, in maternity, I can't say for nursing because I'm not in that world, but certainly in maternity, it's a stretched and busy, scarce workforce, and we just have to take baby steps, but eventually we will reach all levels. And you are correct, Colette. You know, we do need to think about these other players because they fit into the care pathway that we deliver. But it's one of those situations as well. It might not be direct online learning or face-to-face learning. It's what you learn on the job as well. That's also important in terms of your shop floor experience, so to say.
Would you like to add anything, Ed or Naomi? Or Emma?
Yes, I think, well, just from the national programme perspective, obviously when we're looking at scoping the pathways that we described that we're looking at, we are looking at whoever's delivering the care in those areas. So we're not asking, are you registrant? Something like, for example, the first pathway did focus quite a lot on specialist practice. But then the pathway after it included a whole range of different professionals and voluntary groups and patient groups as well. So from our perspective, we're not drawing any lines on that. It's more about who's appropriately involved in the patient care. And yes, we absolutely recognise that these days a lot of the things our public may think a nurse does, a registrant does, actually it's you know, a healthcare assistant or even or someone else who's doing that now.
Yeah, so I mean, it's such a good point because obviously nursing and midwifery workforce is supported by quite a large. I think the term unqualified sounds really rude because a lot of these staff have done a lot of NVQs, some of them are associate nurses, so they are qualified, but perhaps not professionally registered is perhaps the way to put it. So, has anybody got anything? Oh yes, they're at the back.
Hello, Paul Selby, the pharmacy lead for the GMSA. I'm sorry to single someone out, but I wanted to ask Denise a question, which was, I was listening to your talk, which was brilliant about how you'd got your training midwives to refer to fetal medicine rather than waiting for that to happen in the antenatal clinic. And I appreciate that you're waiting to get the results, but I was interested to hear how the midwives who were doing the referral found that and whether they felt empowered, whether that was a sort of benefit from them.
So are you asking if the clinic midwives felt empowered by being able to do that direct referral?
Yeah, exactly.
Yeah. We got some really good feedback from the community midwives and the booking midwives. I think what we explored was the reasons why they weren't doing that direct referral in the first place. Was it to do with our pathways not being effective? Have we not communicated that? Is there a barrier between midwifery and clinical genetics? And there was, and it wasn't a physical barrier, it was just that lack of confidence in being able to liaise with that multidisciplinary team. And once we opened up that ability to be able to link directly with the clinical genetic team, it was just like a light bulb moment. They're like, oh, right, so I can now just do that referral and the patient will get seen. Or even like Jenny described with this gap referral. So we had this problem where they were not able to raise a query, so they felt they didn't have that expertise, and that's fine. And they were sending them to the antenatal clinic for the obstetricians, who equally don't have that expertise. So it worked really well to empower the midwives to say it's okay to not know. Jenny's example of the Dravet syndrome, who in the room knew about Dravet syndrome, and that's okay to not know, but you need to refer her on to somebody that does know. It just makes it easier, but breaking down those barriers and empowering the midwives to do it, they felt so much better for being able to do it. And, you know, you want to support that woman through her pathway, and if you're not able to, you have to keep sending her off to other places. That's delaying the referral and not really using the best of your expertise. So, no, got some really good feedback from it. It was only a very small pilot in Leeds at the moment, but we're hoping to make that bigger. And I hopefully it's inspired some people across this area now to look at their pathways too.
Any further questions?
I just have a question about your resources that you showed on the slides. Are they going to be available for people to sort of use across the country? You're going to keep them to yourselves, or they look really good and I like to pinch them?
Yes, you can have them.
How do we get them?
So we haven't, we still have to pilot those as well. So I think what we've learnt by doing this, really, what we thought was a really small regional project now has such a fantastic reach across all of midwifery. It's so lovely to see our colleagues now engaging and wanting to be part of this part. We've been able to do that resource exploring. We need to pilot it first, and we've linked with our genetic counsellors to get the right input into these resources. They will not be perfect. There will always be someone that's got another opinion that wants something else putting in. That's fine. But we've made a start, and once we've got them gone through our sort of ratification process, we're going to look at how we're going to share them, most likely using the GMSA websites, because that's a good resource for everybody to use. But no, once we've tidied them up and made them look a bit more pretty, then yes, I'll happily share them.
Thank you.
Anybody else? Yes. And if you just wouldn't mind introducing yourself.
My name's Anita, and I'm one of the gynae Macmillan nurses in Northampton, and it's really for you guys about one, really about the Lynch syndrome. Is there a specific session that we could do, you know, for a learning point of view? That we're planning to set up clinics so that we actually see the patients and go through and counsel, etc. So is there anything you would recommend us doing, you know, to make sure that that's set up properly?
Yes, definitely. So RM partners have a lot of resources on there, and I'd suggest that you do the training there. But also I'm happy to do either virtual or physical training sessions, and we're there at the other end of the phone. So on a real world situation, we can help you patient by patient. Before that, yes, we can do some training.
Vicky, can I just ask you a question on Lynch syndrome as clinical lead? So I know we've got a couple of Lynch syndrome CNSs here today. And I just wondered, I know we've got our GMSA regional network. Is there any thought to a regional network for Lynch CNSs to sort of share, practice and learn from each other? I'm not suggesting you lead it, but I'm just, it just...
So there is a network for the transformational nurses within the project, but the actual nurses on the ground doing the training at the moment, there isn't a network. I think nurses doing what we call mainstreaming is going to become more and more prevalent, so having people tied into education is going to be really important. So that is something that we could look at.
That's brilliant. Any more comments or questions? I'd like to just highlight Lisa Flinton's service. So one of the work streams we were working on was familial epilepsy, and I know in the nursing stream this afternoon Lisa spoke about this, and I sort of thought, oh, I know that epilepsy is much more prevalent in the population with learning and intellectual disabilities. So I thought, oh, there's going to be quite a few services for epilepsy run by the mental health learning disability trusts. And I was quite surprised to find that I think Lisa's service at Notts Healthcare Trust is probably unique across the East GMSA. I think there might be one down in Hertfordshire, which is run by the local authority, but that surprised me. And I'm sort of hoping that perhaps some of the things that come out of our GMSA work streams, because obviously we can't tell NHS England what to do, but we can make suggestions and advise and lobby for change, so it's better for our patients.
I think
So-
just to comment on that, I think epilepsy as a condition tends to sit in adult neurology rather than as in a specific learning disability kind of team. And we are blessed in Nottinghamshire. We have a great forward-thinking trust who I've kind of worked with for many years. But it's definitely an integrated service with the acute service in NUH, the Nottingham University Hospitals, because without that, our little team from the Learning Disability and Mental Health Trust, we wouldn't be able to do what we do without this integrated working within Nottingham University Hospital. So that's invaluable, and having a clinician lead, as in the team we have in neurology. But then we do also need that backup from the clinical directors in Nottinghamshire Healthcare to support us, to allow us to be employed to provide that service. So yeah, we have great joint working. Without that, I mean, I'm just talking about networking with specialities. So in the epilepsy world, we have a nursing association called the Epilepsy Specialist Nurse Association, where we network around and we meet a few times over the years. And there are definitely lots of learning disability nurses who specialise in epilepsy purely because of the knowledge base and the prevalence of that. But they do tend to sit a lot in the acute areas, rather than, as you say, a standalone kind of thing with in a learning disability trust. But no, yeah.
And can I ask, do you accept referrals from outside of Nottinghamshire?
We do, yes, we do, yeah. Well, not so much on the learning disability side, because we're purely commissioned for the area, but definitely on the adult side, we do tend to see people from Leicestershire, Derbyshire around the areas, yeah.
That was my...
Lots of families who've moved away don't want to lose our service, so they still come back to Nottingham for that acute service, yeah.
That's good to know. That was my ulterior motive, to send people your direction.
Yeah, not too many. Yeah, thank you.
Yeah, so that's a great example of how organisations are working collaboratively for better patient outcomes and better quality of life for patients, which is why we're all here, I think, I hope. So any final questions or comments? If you can't think of them now... Oh, Emma, sorry, I didn't see that hand sneak up there.
I thought I'd be a little bit like you and be a bit menacing to the participants here. And I was just wondering whether there are any particular things that anybody wants to say that they're going to go away and do after this event. Are there any sort of must-dos when they go back to their day job that you'd like to share with the rest of the room?
Yeah. So I'm good. Oh, Janet, thank you. You've saved my life.
So I've already started the conversation. So I'm going to stay in contact with the midwifery colleagues who spoke today, and we're going to get under the skin of Jackie Dunkley-Bent, and we're going to strengthen that strategy for England.
Amazing. So I think what I'm going to do, I'm going to come to each table now for something. Anything.
So I'm a student midwife. I was a nurse originally, and now I'm a student midwife. So I think now what I'm going to do is just look at the pathways, make sure that I know them. So when I qualify, I know exactly what to do in terms of referral. Yeah, thank you.
Fantastic. Helen and Angela.
So I think Denise's kind of conversation was really interesting to me, because it's kind of having that conversation at booking is so important, and obviously time pressures, as we heard people have half an hour to 2 hours to have a booking, which is a massive, so much information to fit in such a short period of time, and making sure that that conversation is valid and we're picking the right things out. So I was very interested in your red flags, so thank you for sharing those. And also the R21, so the extended screening. I'm a district general hospital, so it's ensuring that our ladies have equal access to that via our tertiary centres, but it's making sure those pathways are in place. So lots of work to do.
Thank you.
Hi, yeah, I'm Ruth. I'm the head of midwifery in Nottingham, and just hearing the conversation today has really made us as a team think about how we share the information with the wider maternity service in Nottingham, especially thinking about all the work we already do that would fit under this category that I don't think is particularly recognised within the service. So sharing, just raising the profile of it and sharing with midwives what we're already doing, which is quite considerable within our service, but also just thinking about next steps and what that looks like for us and the team here from the fetal medicine service, and they've got quite a lot of things on their list of what they want to do next, and I think there's some emails coming your way for the panel. So yeah, great input today, thank you. It's been really, really encouraging, it's been really interesting, and we've gained a lot from it as a service already, just hearing what you've said today, so thanks.
Oh, that's brilliant, and it's fantastic that you've come along and started those discussions. I think we've heard from this table twice. This table? Leanne, is there anything you'd like to say? Sorry to single you out there.
So it was just thank you to everybody. I know I touched on it earlier, but the work that you're doing for as patients and the awareness and just having these chats and spending the days like this and spreading it out to the wider team is valued from our side. So thank you very much.
Thank you. Anything from this table?
My name is Pauline Rule. I work for Leicestershire Partnership Trust and work in community settings. So for me, this has been quite inspirational because I knew very little about genomics. So for me, it's just the basics of making sure that my team are aware that actually there are national programs out there and what impact we can make in terms of having conversations with patients and being able to signpost them for additional services. We were having a reflective discussion on my table about personal issues, and one thing I was reflecting on as a mum of children with learning disabilities, how you spend so much of your life blaming yourself for that flight that you took when you were pregnant, or was it this, was it that? And I think now we're hearing, well, actually a lot of it is down to genetics and, you know, stuff that can't be actually attributed to your personal sort of choices in life. So for me, it's been quite liberating, and also I intend to then share this information with my teams. Thank you.
Oh, thank you. That's great. That's great. Did I come to your table? No. Would you like to say something?
Hiya, I'm a gastro-nurse specialist from Nottingham. Similar sort of just an introduction to the world of genomics and how we can sort of potentially use it for some of our patients and identify sort of certainly patients with Lynch syndrome has been probably the most prevalent one for us, how we can help those patients a bit more.
Fantastic. It's just nice to get you joining in a little bit, because I know you've all been sitting, and I think this might be the final table. Does anybody like to make the final comment? Would you like to?
Yeah. Hello, everybody. I'm Silvio. I'm one of the ICC nurse specialists in Nottingham, so I work in cardiology. And so by attending today, I just realized how much learning on the way I have to do still, because so I think it is a service we can develop to future potentialities, and so I believe that being able to do networking with the other services would be of invaluable help, because it's such a kind of new specialties. I believe that being able to develop genomic medicine to help our patients and their family will be a leap forward.
Oh, thank you so much. It's so great that there's so much positive energy in the room for taking genomics forward. Sorry I've got my back to you, but you can hear me. So, if there are no final questions or comments, shall I close the day? Well, thank you all for coming, and it's been great meeting you all, and thank you for participating in that last bit, because I just thought, you know what, I've talked quite a lot today, and it's and it's quite nice to hear different voices and different perspectives, and it all sounds like, from everything I've heard, it sounds like you're going to take stuff away and do something with it in your trusts for yourself personally and professionally with your teams to sort of make the genomics strategy, in taking it from a strategy and taking it into real clinical practice. So that's great. And what else can I say? We'll email out the presentations. When we send it out, any questions you want to send to us that you haven't had a chance to ask today or they just occur to you, please ask them. There'll be the customary evaluation form, which we value all of your comments very much. So thank you all very much for a great day. And a big shout out to our speakers. Big shout out to Ian, Katie, Vicky, Chris, Naomi, Emma, Ed, everybody. Thank you.